Ladies and gentlemen, good morning. I am trying to observe all protocol, and good enough the moderator has gone through some of this. Let me take the opportunity also to welcome you to this very important conference on safe motherhood, and I will go through a few things of where we have come from, some of the developments that have taken place over the years, and where we should be going. I had asked these people to put one or two slides about some of the things that used to be done. I will start by saying that the Safe Motherhood Initiative, some of you may have heard about the Safe Motherhood Initiative. It was a global effort which was launched in Nairobi, Kenya, in 1987. And this was the Safe Motherhood Initiative. And since then, it has been brought to the fore. The purpose was mainly to curb the very high maternal mortality and morbidity that was being experienced at that particular time. I should say that by that time, the maternal deaths globally were about 500,000 deaths per year. It has markedly reduced over the years, but you could see that there was a big issue that needed to be sorted. And I will even start from here by saying that it is very vivid in my mind, because when we came to for postgraduate training, one of the professors who had attended that conference, that initiative launched in Nairobi, had gotten questions to ask. So one of the essays he gave out was, write an essay about safe motherhood. And we were told that the people who were there really had to struggle with it, because most of the people had not heard about it. If we could have the slide which has some of the things that used to be done at that time. But as they do that, I mentioned some of these things that were being done in 1987. Some of the people may not even know that some of these were happening. One of them, patients who had eclampsia used to be managed in dark rooms. So labor wards would have dark rooms whereby if somebody had fits, they would be put there. So you can imagine how that would be, including how they would be monitored. They were using entirely what is called the midline Sabambaleko incision. Some people call it the up and down incision. That time we didn't have the phanestoid incision. So you can imagine, and we struggle a lot with it. So this phanestoid is quite new. All the anesthesia for mothers who are going for delivery was the general anesthesia. So mothers would not even know when their babies are being born. They would be told later on that your baby is fine. So you can see where we are coming from. Cattegat was the only suture being used for episiotomy. And as you know, it is associated with dyspareunia. Mothers used to be kept on the ward for 1 week after surgery. And actually, if a mother wanted to go home like after 4 days, the health workers would struggle with her, and there would always be some form of fight. So then we had this issue of non-absorbable sutures for suturing wounds. I was managing a lot of patients. One time I visited one of the patients on the ward. She was very, very anxious. She said she had not slept for 3 nights. The reason for that is that they had told her that removing the suture was very, very problematic. That at that time, we were beginning to get the absorber ones. She only calmed down when we told her that actually the suture you are having is not going to be pulled out. The nylon was being used and was it's very, very painful. It is good that some of these things have actually changed. Mothers with multiple pregnancy would be admitted. If a mother was diagnosed with multiple pregnancy after 28 weeks, that would mean automatic admission until delivery. They were thinking that bed rest could actually prevent premature labor. So I have just picked out some few. There are very many other examples that we could really look at. But the reason we are bringing this is that from the Safe Motherhood Initiative and what we are seeing today, what are some of the things that have been done and what can we improve? A slide with indicators So in that line, I would want to share some of the few slides, some few that I have picked out that are of use or that we could use to track some of the developments that have taken place since. And as like one of the slides that was moving around, most of the information is from Uganda Demographic and Health Survey. It is also very, very important to realize that Demographic and Health Survey, we started doing them in 1988-89. So it is not like they were being done very many years before. And as you know, they are supposed to be done every 5 years. So there have been lots and lots of developments, and we'll pick on some few. Maternal mortality ratio at that stage was about 524. And you can see how it has moved over the years. We actually also used to have mothers who would tell us, but mothers used to deliver so much in the villages, but they were surviving. So we would say, bring the figures. And that's where the use of data become very, very important. Because you could see that these people who are saying that the mothers were actually surviving were not right. Because at that time, the deaths were very high. And you see it has been coming down, 506, 505, 435, then went up slightly, 438. Some people here say it is because of the methodology that was used to calculate. Went down, and now we are at 189 per 100,000 live birth. Please note that it is a live birth, and that live birth has got an issue also because the mothers who have IFDs are likely to have even maternal deaths, but they are not usually included in that calculation. The other one we could pick out that is of interest, supervised deliveries. You could see that for a long time, it was at 38, and now it is at 91%. All these have got very clinical, very important significance on how we can leverage on these to make sure that we save more and more mothers. In fact, one of the arguments here, some people had decided to support traditional birth attendants. And the reason was that, after all, many of the mothers were not coming to the health facilities. And you can see that was the basis. But as you know, we have reached a level where those had to go completely as more and more data was coming in. So this gives us quite a lot of having an idea of where we were coming from. Now, there is another big advantage we can see in those figures, the issue of antenatal care by a skilled provider. We are aware that almost 98% of our mothers attend antenatal care at least once. And that is very, very important, because if we are to save more mothers, I could say it at this stage that we should utilize that single visit. We should actually not know that these mothers will come back and we can do more tests. If we could focus on that particular single visit that has happened and we utilize it maximally, do the tests, do the history taking, that would really push us a lot. Of course, there are people who are interested in things like fertility rate. You see that it is going down, and this goes down together with the increasing contraceptive use. So it's important when we have this, then we can be able to continue moving and progressing. Now, research was at a lower level. What has happened is that over the years, we can now refer to research that has been done by authors from Uganda or from the region. And this is in terms of articles published in international journals, in terms of books. You realize that the writing has increased. And for example, Magpie was one of the trials that he brought to the fore the use of magnesium sulfate. And some of our people like Melda Namagembe were involved. And it changed this issue of having people in dark rooms. There was also something called the elephant mixture. If somebody got eclampsia, they would sedate them so much that they would almost go into coma. So all these, you can see where we are coming from. Women trial, tranexamic acid with Christine Bidiabale, manevirapine. This, you remember, was a global thing. Professor Miro, emergency contraception, initially was an issue. The speaker was one of those who participated significantly in bringing it. There are areas also which we can talk about, but which have remained only in our countries. And one of these is obstructed labor. Obstructed labor, now the only people who are writing about it are people who are in the low to middle income countries. Because for the high income countries, or what we used to call the developed countries, this is no longer an issue. In fact, even when you want funding, you find that it doesn't really come up. We are also having people who are being recognized globally. And we have had people like Jeremy Yeza being recognized at FIGO, Florence Mirembe, and the other week there was a FIGO meeting at Cape Town, and we had one of ours recognized, that is Professor Nashmli. She was speaking at the start of the video. FIGO is Fédération Internationale Gynecologique et d'Obstétrique, and it brings together all the obstetricians. So the reason why this is important is that having started from those indicators, having all of these people with us, is it possible that now we can actually target, continue to save more mothers as much as is possible? As a country, we have a number of figures that are so much to the fore, and the documents, we have got the issue of NDP4, which is geared towards accelerating Uganda's transition from a largely subsistent economy to a modern and prosperous society by 2040. And that also means a lot. People can only move in this way if they are healthy. And we need to see how to continue to embrace this. We have got and are part of the Sustainable Development Goals. Remember, there are 17 of them. But we have focused a lot on SDG number 3, which is aimed at reducing the global maternal mortality ratio to less than 70 per 100,000 live birth. Now, that is, to be specific, that is 3.1. On this one, I want to bring out another big part that we have to consider as we try to embark and develop and improve maternal health and newborn health. That some people, even when they are talking about reducing the maternal death to less than 70 by 2030, you will hear somebody saying that, but Uganda won't be able to achieve this. I am bringing this up because I want to bring the aspect of positive deviance, positivism, that we need to remove this aspect of some people being negative, that we won't do it. We need to move to where we can say we can do it, because we have already shown that we can do a lot by the figures that we are looking at, the indicators. And people who have positive deviance, you can find that a society, all the people in a village don't have food, but you'll find one home in that village which has got food, and you wonder how they are getting it, and yet they are living in the same area. So that what we are talking about is that if we have these good practices, let's keep them, and let's see how we can share the good practices, best practices with other members in the group, and in the country, and in the society. So you can see that we have a number of figures that we are looking at: 2030, 2040, and we should have positivism, and then we shall be able to move faster. However, as far as the SDGs are concerned, we want to emphasize that we should not focus on SDG number 3, because even the others are contributory to safe motherhood. Aspects like SDG 4, which talks about quality education, are key. Clean water and sanitation, number 6. Issues like number 2, which talks about zero hunger. Some people say, how does zero hunger contribute to safe motherhood? In very many ways. But the simplest we have is that if nutrition, childhood nutrition is poor, it will mean that a mother is right, this person will grow up but will have a contracted pelvis. A contracted pelvis will lead to obstructed labor, which could lead to death. So what basically this means is that for us to succeed, we have to work with many other groups, like the theme of this conference is talking about, multi-sectoral. If somebody is supporting education, we should support it as well, because it will contribute to health. And if somebody is talking about nutrition, we should really do that as well. We have an aspect about Agenda 2063, but how we are bringing this in is that the maternal death that occur. I usually teach a topic where we are talking about maternal death, and I have reached a level where very many questions have come up, because we say that most of the causes of maternal death are preventable. Then when they add on the next sentence, they say most of these deaths are occurring in sub-Saharan Africa. So when you keep saying this year in and year out, you kind of get challenged. You say, what is so strange in sub-Saharan Africa? This geographical location. You can see that now we have all these people who are writing books, who are publishing, they are doing PhDs. We need to reach a level where we can get annoyed and say that some of these statements need to change. Because remember, Uganda is part of the countries in sub-Saharan Africa, and it is being counted all the time. All the deaths are there. These deaths are preventable. So all efforts should be put in place to make sure that we can prevent these maternal deaths, and also change the literature that keeps coming up from and talking about sub-Saharan Africa, which even has a lot of resources. As you know, members, it has lots of resources, including minerals that are very, very rare. So you find that we just need timely skilled care, essential medicines and equipment, functioning referral systems, and financial access is very, very important. Our partners in development, but also the country itself must generate funds. So strengthening the whole continuum basically from preconception care, antenatal care, skilled birth, emergency obstetric care, and postpartum care. We also want to urge our partners in development and all the members who are here that we need to put more funds. We need to put funds in the labor wards. There is an observation that most of the funds tend to be put in things which are easier to achieve. Things like immunization, which is good, yes, but if you handle these mothers who are in labor ward with the many different parts that are needed, that making sure that all the people who are there can deliver the mothers very well, they are skilled, adequate human resources, it would be very, very important. We have to embrace digital health critically, artificial intelligence, machine reading, and see how they can come in to help us achieve all aspects to do with safe motherhood. We have also, yesterday, new guidelines were launched for research in Uganda by Uganda National Council for Science and Technology. And one of the things being emphasized is community engagement. And there is also this big concept that has come up that we must embrace. That is nothing for us without us. And basically what that means is that if we talk to the communities, the mothers in the communities, the men, they know what they want. And we need to see how we can embrace this, consult them. They know how they can reduce maternal deaths, but most of the time, we tend not to have them on board, and at times have the health workers on board and researchers. But let's get to the nothing for us without us. I will now talk about a few things about NASMEC, and basically that's how it comes in. It was observed that there was like a gap. We have the Ministry of Health, we have the professional organizations, we have universities, but when you talk to our people, it's like they need a lot more information. And so NASMEC, which is now National Safe Motherhood Expert Committee, as it started, had a number of thematic areas: research and development, medical education and training, policy and leadership, quality of care improvement, advocacy and engagement, and monitoring and impact evaluation. In the interest of time, I mentioned that it has achieved a few very important things. One of the critical ones which had not come up was the essential maternal and newborn guidelines, and they took a lead in this. The local maternal and neonatal system has contributed tremendously to what is currently happening, and in terms of reducing the deaths. In fact, before the DHS figures came out, we had observed already through this LMNS that the deaths were reducing. So it was not like by surprise. What the LMNS has done, and I want to emphasize this, it has encouraged interprofessionalism. Obstetricians, pediatricians, anesthesiologists, but also people who are not direct in the health sector, like CAOs, the partners in development. You find they are on the same forum and they can quickly share. But also institutions used to run separately. Like Kisenyi is referring patients to Kawempe National Referral Hospital, and I can see the director here, Dr. Manuel Byaruhanga. And they don't communicate. So mothers just land there, the labor ward is full. So this has helped a lot in terms of warning, and also some of, for example, Kisenyi attending meetings at Kawempe National Referral Hospital. We have, the other big thing it has done is institutionalism, making sure that these institutions work together, apart from the professions, but the institutions as well. And I can see Professor Pius had started the aspect of institutionalism, but never moved it very fast, so it has been taken up. Then there has been improvement in the MPDSR. And then advocacy groups for PPH, sepsis prevention and treatment, safe birth, preeclampsia and eclampsia and PAC. And all these, so when these professional engagements would take place, you'd find that there are about, initially it was 500 people, the cap, then you realize that the need was so big that it would go up to about 1,000. And people want information, and we need to keep seeing how we can share information and have it delivered to everyone, so that we are equipped to save the mothers. We need to put ourselves in the picture that these mothers whom we see having complications dying, they are like us, and we are assigned the duty to save each of these mothers. Each of these babies you see gasping for air. What can we do to save these babies? As we are in this Safe Motherhood Conference, we need to be sure that we can really handle that. And so, these very many activities needed to be streamlined, to be more organized. And what has happened now is that we are, the NASMEC Institute has been formed to try and streamline all these activities so that there is more coordination from that angle. And what each one of us can do in our different capacities, let's make sure that we contribute and save more mothers and save more babies. It is basically our duty to do so. Within the short time that we have, I think we have to stop at that, but I would want to challenge and say that each one of us, we are starting on this part, each one of us, each one of you here, seated here, and the people you represent, challenge them. What can we contribute to save this mother who has come in with complication with eclampsia? How can we prevent it? How can we save the babies that people see having challenges in our hands? If we did that, we can be able to improve those indicators, and also we shall be able to reduce all the deaths that we have talked about. What that was demonstrating the silos. We want these silos to break. Let institutions work together. Let everyone who can contribute to maternal health have an addition, and we'll be able to achieve a lot. Thank you very much.
Thank you so much, Professor. Ladies and gentlemen, let's give Professor a very big hand clap. Very, very big hand clap. Now, you realize I did let Professor speak for some time because he was doing the ice breaking, but also giving us the preamble for this conference. The history for this conference has been laid out by him. Those of you who have lived longer than longer like some of us, you know that whatever he has been talking about is very true. So we've come a long way, and I want you to thank yourselves for being able to achieve what we have achieved as a country. As Professor was speaking, I saw a number of dignitaries moving. So many other people have joined us, and I know there will be a time for them to be welcomed. But allow me to say welcome to this Safe Motherhood Conference. Now, colleagues, again, join me in welcoming Dr. Joseph Byamugisha. Dr. Joseph Byamugisha will be taking us through the EMLOC Facility Network optimization process, and I'm pretty sure he will do this in less than 15 minutes. Dr. Joseph, over to you.
Yeah, thank you so much, Dr. Alan. I request that my presentation is projected. My name is Dr. Joseph Byamugisha. I'm going to present to us an EMOC facility network optimization process that we did as Ministry of Health with support from UNFPA and other partners. As you can see from the screen. So just to save you from a lot of background, in 2023, the country conducted its first EMOC facility network EMOC facility assessment in Uganda, and then from there we identified quite a number of gaps. And so from those gaps, one of the recommendations was that we should be able to prioritize on the process of upgrading and functionizing the EMOC facilities that we have in order to have services available, but also have improvement in quality. So we did this work in December 2024. Next slide. So the outline of my presentation, I'll take us through the EMOC situation in developing countries, and then we shall look at background, which look at the country profile, then the Uganda healthcare system, which we're well versed with, then the maternal and newborn care landscape, the objectives of the optimization, then the approach that we used, methods, and then the profiles of the regions that we did, and then the key results. Finally, with the recommendations. Next. Yeah, so when data from 15 developing countries was analyzed by a team, the AMDD team in Columbia University, they found out that most of these developing countries set very ambitious goals in terms of the numbers of facilities that should be functional. But then this ambition is actually way higher than what the international standards recommend. And probably I can't point, but that's the orange bar. And then the green bar is what actually that is ideal, where you find most of the countries operating from, below the international standard. And when you include in a component of quality of care, it is even worse. So the role of the optimization process was how, instead of focusing or being too ambitious, as you can see in that first bar, would rather have very few facilities that are functional, but then accessible by most of the population. And this is what I'm going to talk about mostly. Next. Yeah, so we can move next. We can skip this. Yeah, so this is the structure of our healthcare system. We are well versed with it. Next. Yeah, so the maternal and newborn landscape in Uganda, you notice that we have been making quite some progress, if you can see from those trends. From the late 90s to early 2000, our maternal mortality ratio was in 500s. But as of the UDHS 2022, we have really improved, and we are at around 189. And so if you look at the under 5 mortality, and you disaggregate it into the infant mortality, but also the neonatal mortality, you can see that there has been some remarkable progress in the under 5 as an aggregate. But then when you look at the trends, for instance, for neonatal mortality, it hasn't improved as much or in the same manner. However, in terms of the opportunities that we have, institutional delivery rates, the mothers who are delivering in institutions have been increasing. So we have, according to UDHS, 86% of our mothers being able to deliver in facilities. And this is a huge opportunity. And so that would mean reflexively that those who are delivering from home are reducing. That is in the last graph. Next. Yeah, you can go next. I've already talked about that. And even the next one is just a repetition to show it just in a bigger picture. And so we can go to the EMOC facility network optimization and how we approached it. The objectives of the EMOC network optimization, the main objective was to optimize the emergency obstetrical newborn care facilities as a network. And here we considered 4 regions. That is Kampala Metropolitan in terms of the LMNSs. Then Karamoja region, Acholi, LMNS, and then West Nile. West Nile has now been divided into Yumbe LMNS and Arua LMNS, but for purposes of this presentation, they are combined. The process involved a situation analysis, and we basically benchmarked the EMOC assessment of 2023, which was mostly facilitated by UNFPA, from where we identified those different gaps, and then we're able to convene teams from the different local maternity and neonatal systems in order to plan this optimization network. That was in December 2024. And then the next phase, which we are currently doing, is monitoring and quality improvement, where we are collecting data and tracking the progress in as far as functionalizing these facilities is concerned. So in the methods, it is basically what I have talked about. We selected 4 regions, and then we support from different technical teams, that is WHO, UNFPA, Ministry of Health, University of Geneva, Mackay University. We're able to use Access Mode and GIS, which do geospatial mapping, to map facilities and how far they are from where people stay in terms of population access. And so when we did that, we're able to come up with a network of facilities such that if we prioritize those facilities, then most of our people are able to access functional facilities. And I told you the issue here is we have so many facilities, they are very accessible, but they do not have all the services. So instead of spreading the thin resources, we'd rather focus on fewer facilities, make them functional, but they are covering most of the population. And you'll see in the results. Next. The profiles of these regions, we used, we merged data from different sources. So Acholi has 8 districts, and its population size as of the 2024 media population from the National Population Housing Census was about 1.97. And so if we use the international standards of the number of EMOC facilities per 500,000 population, where we have, or we should have 5 functional facilities, of which one should be a CMOC, then we would require 20 facilities. However, from the assessment, we had only 5 functional facilities, and the gap was 15. And the picture is not different from the rest of the regions, as you can see. We can go next slide. So when we aggregated the 4 regions, the total number of facilities which were aggregated were 133. And this was from 248. And that meant that if we concentrate on 133 facilities from the 248, we can be able to achieve optimum coverage, as you can see in the percentages I'm going to talk about. The first one being, when you look at access to these facilities within 1 hour before you consider whether they're functional or not, it is high and it is expected because we are ambitious. But then when you look at access to the fully functional facilities, say in 1 hour, it is 71% of the population, which leaves around 29% of our population not able to access these facilities. And after optimization, this is the aggregate for all the regions combined, you can see that access to these facilities within 1 hour is 91%, which is quite some good improvement. And if I go to the individual regions, that is starting with Acholi region, we can move to the next slide. If you look at Acholi region, the total number of facilities are 80. Those that are designated EMOC are 60. However, the fully functional, those that are able to perform all the signal functions, the EMOC signal functions, the 9 signal functions, were only 5. And so when you look at access to these facilities before you consider their functionality, you find that 1 hour coverage, excellent, 98.8%. 2 hour coverage, 99.8%. But then if you look at access to functional facilities, the fully functional facilities, you can see that we have 74.8% in 1 hour. That means about 25.2% of our mothers are not able to access these facilities within 1 hour. And you can imagine if someone has an emergency, how much golden time that you will have in order to save this mother. And so when we optimized, you'd find that the total number of facilities included in this network for Acholi were 22. You can also, the number has gone down. The BMOC are 7, with CMOC 13, and IEMOC, which is intensive EMOC, a new classification, 2. The 1 hour coverage, 97.7. So we can bring these resources together in order to have these facilities functional and accessible within the shortest time. And so, next slide, if you look at, that's just a pictorial representation of the same. You can go next. The picture for Kampala is not so different. The difference is that Kampala is mostly reliant on private sector, and so the facilities are so many. The access is very good. However, you can see the gaps. And you can go to the next slide, which brings out the picture, and you can look at the color codes in terms of access. And for Kampala, because facilities are too close, we're able to do 30 minutes and 1 hour intervals. The picture in Karamoja, which is the next slide, in terms of access to fully functional facilities, if you start with access to all facilities, it is obviously good before you consider functionality. But then when you consider access to fully functional facilities, you can see that in Karamoja, we didn't have a facility which was performing all the signal functions, and the other issue was assisted vaginal delivery. However, we had some part of Karamoja being able to access some facilities naturally at the border. That is why we have 3%. And so after optimization, we moved from 0 to 45%, which is a huge leap within 1 hour. Still wanting, but at least a good improvement. And so West Nile, the picture is not different. I'll just comment about the human resource gaps, because the optimization also looks at human resource gaps and also the referrals. Those color codes, I will not talk about the specific figures, but you can gauge the relative size of those bars. Blue is the gap for midwives. Orange is the gap we have for nurses. And then the gray is for doctors. And then the yellow is for anesthetists. This is from the 2023. We compared the situation that is in these facilities and the public service staffing norms of 2023. And those were the gaps. And then on the referral gaps for the EMOC facilities, next slide, we looked at quality of these referral linkages, that is referral from the basic emergency obstetric and newborn care facilities to the CIMOC facilities. And you can see that in Karamoja, we don't have facilities that can refer, that is from BIMOC to CIMOC, within 2 hours. However, between 2 hours, we have about 66%, and then more than 4 hours, about 17%. And this shows you how hard it is to refer mothers from BIMOC facilities to CIMOC facilities in these respective regions. And you can see the picture in Acholi, which has slightly improved if you compare with Karamoja, then for Kampala, and then West Nile, where we are slightly doing well with most of our facilities being able to refer between 2 and 4 hours. And you can see that if you need 2 and 4 hours to reach or to move from a BIMOC to a CIMOC, then there is slightly a problem. Yeah. Then we can go to the recommendations from this work. From the gaps that we saw based on the public service standards of 2023 and the status which we picked in 2023, then we see that we need to recruit, mentor, train, and retain key cadres, that is midwives, doctors, anesthesiologists, and other essential health workers in these facilities. And then a phased annual infrastructure upgrade and equipment upgrade, because these were some of the weaknesses we saw in the facilities. Then the referral systems, the ambulance services, and how they move could be remapped to reimagine how the movement should be. Should it be an ambulance at the referral facility or an ambulance at the referring facility to save time, that little time that we have? And lastly, the comprehensive referral protocols that will guide this process. The next steps, which is the last slide, we need to discuss the norms for EMOC to contextualize from the global norms to our local norms, and then for the small and sick newborns, and including the HR and the referrals. Then the role of the LMNSs in this kind of optimization, which is work that is actually currently ongoing with support from UNFPA. And then the quality of care indicators should be monitored, because you saw that although we are too ambitious, when you factor in the quality of care, then the performance might slightly go down. And then we need to contextualize the EMOC signal functions like assisted vaginal delivery what levels should be performing this, and then how should we assess these facilities. So I'd like to thank again UNFPA, WHO, UNICEF, the NASMEC Institute, Makerere University, and University of Geneva for supporting this work. Thank you.
A bigger hand clap, ladies and gentlemen, for Dr. Joseph Byamugisha. Now, we all accept that there is no way we can save the mothers and the children if the BMOC and the CMOC functions are not strengthened in this country. And he also brings in a very important aspect of how can the LMNSs be empowered to ensure that they take this up. Well done, and thank you so much. So, colleagues, I want you to join me in thanking Professor Byamugisha. Those of you who missed his presentation, very powerful, about the history of where we've come from, but also talking about the objectives of this conference. So thank you so much, Professor Byamugisha, my teacher, and also join me in thanking Dr. Joseph Byamugisha for the high-level presentation on EMOC optimization. Allow me hand over back to Dr. Bagala to take us to the next session.
Yes, thanks very much indeed, Dr. Alan, for taking us through the first session. Ladies and gentlemen, we're good at time management. We're a little bit short by 30 minutes, but we shall see how to compensate. And the next session a little bit builds to some of the incredible work UNFPA is supporting in Safe Motherhood, because UNFPA was very instrumental in this optimization. So I'm very, very happy that next we are having another very incredible plenary session, and that is going to be led by the UNFPA team. And allow me, without any further ado, introduce the session moderator for this, and that is none other than Miss Priscilla Regina Nalwoga. And a little bit about Priscilla. Miss Priscilla Regina, thank you very much indeed. Miss Priscilla Regina is a formidable Ugandan journalist and presenter, bringing over a decade of dedication from both radio and mainstream television, with a core professional vision to empower audience towards informed decisions. She's a highly valued figure at NTV, a flagship brand of the regional national media group, where she actively anchors current affairs and news bulletin to facilitate public digestion of complex issues spanning politics, economics, and human interest. Thank you. Welcome indeed, Ms. Priscilla.
Asante sana. Good morning to you, ladies and gentlemen. I know the weather this morning was not friendly as we were getting here. Many of you could use a cup of tea. So we're going to get a cup of tea from our neighbors. Turn to your neighbor and greet them in your local language. See, we're already warm. In your local language. Now, if you're seated next to a Muzungu, they also have a local language that may not be English. All right, allow me to greet you in my local language. Mwasuze mutia. Mwasuze burunji. We wow. Distinguished guests, ladies and gentlemen, it's my pleasure to warmly welcome you to the 5th Safe Motherhood National Conference. We're deeply honored by your presence as we come together to advance health, safety, and dignity, and this is particularly for mothers across Uganda. At this point, allow me to acknowledge the distinguished guests and key stakeholders that are joining us today, observing all appropriate protocols. Government officials from the Ministry of Health, Ministry of Finance, National Planning Authority, Ministry of Local Government, and other ministries, departments, and agencies. Your leadership and commitment to this agenda is critical to the success of our national safety motherhood agenda. We also want to recognize parliamentarians. I know that today is a unique day for them. Nominations are happening across the country, but those of you that have been able to find this matter very crucial and make it in this room, thank you so much for joining us, particularly members of the Health and Budget Committees, whose oversight as well as legislative support are ensuring that there's translation of policies into real impact. We also want to recognize foreign missions, including high commissions and embassies, whose partnership and international solidarity, it does continue to strengthen our health systems as a country. We also want to give recognition to development partners and UN agencies whose technical support, advocacy, as well as funding remain key enablers of maternal and child health interventions. We also can't forget to recognize representatives from the different professional associations. This is including the doctors in the room, the midwives, and others that are on the front line of championing safe motherhood. This can also not happen by what we heard from our previous speakers, giving us the research and the data that gives us the informed decisions that we have to make. The academia and the economists who are providing us with the evidence, providing us with research as well as analysis. And this is intended to guide effective policy and investment decisions. We also want to recognize the private sector leaders whose innovation, your investment, as well as service delivery is complementing government, complementing community efforts that are currently existing. And then, of course, civil society organizations, we do recognize you, religious leaders, cultural leaders, community representatives. Your voice has been part and parcel of ensuring that safe motherhood interventions remain grounded in the lived realities of our mothers across Uganda. That being said, we are grateful for your presence and for your partnership as you each bring to this critical national agenda collective engagement, and trusting that today you're going to help us ensure that safe motherhood, it's not just a health priority, but it is a shared responsibility, and this is across sectors and society. So once again, I welcome you to the 5th Safe Motherhood National Conference, and thank you for your continued support. Now, for a long time, safe motherhood has been seen only as a health problem, one that is addressed only at the health facility or majorly at the health facility, one solved by doctors and nurses. But as a journalist, we see the wider story: the mother who dies on a terrible road, the clinic without water due to a budget delay, and the medicine stockout that is causing a broken supply chain. So today we want to turn the spotlight onto that very same system, because safe motherhood is not just about medicine. Safe motherhood is about planning. Safe motherhood is about financing. And safe motherhood is about coordination and accountability. So as we need planners, financiers, health workers, as well as community leaders all working together from the same playbook. So our mission here is very simple. In the next 90 minutes, we hope to diagnose the problem that exists within our communities and our health sector. We also hope to prescribe the multi-sectorial fix that can address these issues at all levels. And at the end of the day, a vote to one of these fixes could actually save the lives of many. Giving you the background of it, Uganda has made progress in improving maternal health outcomes, as my predecessors have spoken of. The Ministry of Health's 2024 Annual Health Sector Report did show a decline in the maternal mortality rate to 189, and this is per the 100,000 live births, being drawn from 336 in 2016. So this is a step in a good direction. Yet at the same time, the realities on ground are different. 1,500 women and girls are still dying every single day, 365 days a year, and this is from preventable pregnancy-related causes. Only 64% of births are attended by skilled health personnel, and 58% of health facilities are offering comprehensive emergency obstetric and newborn care. When we look to this very same issue in the rural and hard-to-reach communities, these are facing even higher risks, especially our adolescent girls. Now, while Uganda has made the strong frameworks, including the Safe Motherhood Action Plan, the Section Reproductive Health and Rights Roadmap 2022 to 2026, as well as the Health Financing Strategy, implementation is still becoming a barrier, hindering the fragmented planning, the unaligned budgets, and of course the limited cross-sector coordination. So in this session particularly, we hope to change exactly that, moving from siloed programs to joint planning, smart financing, and shared accountability that ensures that every investment is delivering measurable impact. And this is not just for mothers, but for our newborns, which is the future of our generation. I have been duly told of you that each one of you is very important in this room. Each one of you is very important to the decisions that have to be made in this room for a multi-sectorial approach. Once again, my name is Priscilla Regina Nalwoga from NTV Uganda and Nation Media Group by and large. So that being said, allow me to set the stage. Formally, to stage our conversations this morning, it's my honor to invite a distinguished professional whose work is continuing to shape Uganda's approach to sexual as well as reproductive health and rights. She is serving as the program coordinator for sexual and reproductive health and rights and integration. This is at the United Nations Population Fund here in Uganda. Now, in her presentation, we are hoping that she's going to help us underscore a critical message: the safe motherhood that is not merely a health outcome, but ultimately a measure of national development and the very heart of the mandate for which we're all here in this room. She's also going to highlight for us the true and sustainable progress that can be achieved through system alignment and which sectors plan together, finance together, and review together in pursuit of the shared results. And so, ladies and gentlemen, without further ado, allow me to warmly welcome Ms. Juliana Lunguzi to set the stage for our discussion this morning.
Thank you, Priscilla. And good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Yeah, at least that's better. I'm here to set the stage on, before we have the panel, where we're looking at fixing a thorn when it comes to safe motherhood. And it's really a privilege for me to be here and to welcome you all to this Safe Motherhood Conference. I know you've had a session before, which have highlighted the progress that we have made in safe motherhood in Uganda, and also the challenges that we're meeting. So to us at UNFPA and all of us in the safe motherhood arena, we agree that safe motherhood really matters. But the issue is, why does it matter when it comes to the national development? One key issue that we can agree is that every maternal death remains an emergency in our midst. That's why every Mondays and Thursdays in Uganda, we all sit together and we discuss why mothers have died. It shows that we are all treating safe motherhood, deaths of mothers as an emergency, and that the survival of the mothers really is important, because not only is it important that we don't see mothers dying, but it's also important when it comes to human survival and development. The other issue we need to highlight is that safe motherhood is not a woman's issue. It's a national development priority and a key enabler for Uganda's national development plan and even as we go to achieve our 2040 vision as Uganda. So Priscilla, in her preamble, she looked at the issues of the system shift, where we need to plan together, finance together, and also review together. So for us, working in the safe motherhood space, why do we need to plan together? It's very important that the planning is not only for Ministry of Health, but every ministry and local government must be enabled to embed safe maternal and newborn health into our plans. You can agree with me, when a mother dies, we hear that mothers die because they couldn't pass the road. The mother died because there was no clean water. The mother died because there was no electricity. So you can see that it's really, very important. And another component, yesterday we had the youth conference. It's also very important that we keep the girls in school. Every time you have a girl getting pregnant at 13, at 14, their survival becomes tricky. Not only that, they might survive but end up with a disability like obstetric fistulas. So for us, planning together works well. As some other people said one day, one of the challenges of the health sector is we inherit the failures of other sectors. If the Ministry of Transport can't fix the roads, if somebody can't put water nearby a health facility, We see the challenges in the health sector. So we must take everybody and plan together so that we can fix things. The financing together, with a shifting in financing landscape and declining external support, Uganda really must expand our domestic health financing. We've been talking about these issues. We've been talking about issues of private sector partnership. We have been looking at issues of insurance, the various levels that we are looking at. I know the issues of insurance, not everybody wants to talk about it, but it's a challenge really, because when you go out there, we need money in the health sector. We can't get money from the usual donors. What do? Let's see how best we can finance. Possibly the Ministry of Health might not be the best people to find a solution, but if we work with the private sector, we'll be able to do it. Yesterday we were meeting with Dr. Richard Mugai, and he was saying, all I need is 10 million for an autoclave in one health center. Well, he's not getting it in the health sector, but maybe if you go to the private sector, he'll be able to get it. I was thinking we're finishing the year. Some banks are looking at bonuses. 10 million is not a lot of money to a bank. Possibly if he goes to 10 banks in Uganda, he'll be able to get 10 autoclaves that will save mothers in the rural area. We need to review together. The mutual accountability will really help us to make sure that we see results. Having one results framework, we have all talked about one plan, one MIT. All those are very important for us to make sure that we partner and we can all be accountable to the things that we do to the survival of the mothers out there. You see in the panels that we have a colleague from the National Planning Authority, because we believe that they must understand what the health sector is doing. They must understand that we need to work together, and that all the other sectors, education, transport, energy, water, governance, they are there because development outcomes can achieve more and harmony. We don't need work to work in silos if we need to continue saving the mothers and the babies. And our investment also, we need to look at the health issues of prevention, health promotion, and communities. Issues of family planning, very important. Others say family planning is the vaccine for maternal deaths. We must take this into a reality. And we really need to look at empowering our adolescents so that they have knowledge on how to access services and avoid the early pregnancy. And when all is said and done, let's work with our community. We have the VHTs, we have the midwives, community health workers, to make sure that together we have better ways of saving the mothers. And pregnancy must become an emergency because we didn't plan better. The last thing I want to emphasize in our looking at this thorn is the power of innovation and collaboration. There are so many AI that we need to make sure they are there within our plan so that we can lessen some of the processes that we have to make sure that we deliver better. We must go to the private sector so that we co-invest and see how best we can deliver to the community. So as we begin with this Fix-a-thon, I want to invite all of us to have an honest and bold and collaborative discussion to diagnose what is the bottlenecks and how to prescribe and commit to make sure that we all reach our goals and save the mothers. Save motherhood is not a health expenditure, it's a national investment. When mother survives, the nation thrives. And let us plan together, finance together, and review together so that our mothers and children will have a better future and we can have a better Uganda. Thank you very much.
Thank you, Ms. Lunguzi, for setting the stage for us. It's loud and clear. Just to share a personal story, and during COVID, my sister was pregnant, and unfortunately, because she's diabetic, she couldn't hold the baby for full term. So baby decided to come a whole 3.5 months late, before the maturity date. It was a tough time already by the pandemic. She was in a hospital that was in Chariwajara. That hospital had to move her in the safest and quickest way to the nearest public hospital. But to do that, they had to ask for money to fuel the ambulance. as if the hospital did not have money to fuel the ambulance or consider the critical health of my sister at the time. So we got the money, fueled the ambulance, and then they said, no, you have to first clear the bills here before we can transfer you. That took a lot of time. Please note, she's diabetic and the baby is due any moment now. That was not critical to them. What was critical to them was financing. Their money should be cleared, then you can move out. We were able to do that. Then we went to the hospital that we were referred to, and upon being received, we had to go through the same cycle. First clear ABCD bills. Okay, fine. By God's grace, we were able to do that. And then when she got to be attended by the medical personnel that were on the floor at that time, the immediate response was for them to have her do a cesarean because of the emergency of the situation. Not considering that she has a pre-existing condition, diabetes, that now you have to make a decision, while we want to cut her, what are going to be the repercussions of cutting her, and yet she now has to take care of a baby that has come 3.5 months early. Luckily, there was a senior medical officer on the floor that day. And so he came in right at the time that decision needed to be made. And they gathered and talked through it, and the decision was made that would rather induce her to push the baby rather than cutting her. Then the other issue that we faced was that the nurses on the floor may not have had a good understanding of the already pre-existing medical condition of my sister. So when they were administering the general drugs for mothers who are giving birth, they did factor that in, so the medication that was given to her ended up causing more catastrophe than we needed on our hands. As if that's not enough, now in the neonatal, we're being told we have to also first pay for the baby to be taken there. Then when we do that, then we're being told the drugs, there's that first shot that they give a preterm baby. It is not existing in the hospital precincts. And this is a very big public hospital, by the way. It was not existing. So now we have to figure out, in a pandemic, please note, cars are not, no movement of vehicles or people is allowed. How do we get this medicine from a pharmacy, bring it to save my little nephew? The story is very long, but I'm just trying to show you that it's a multi-sectorial approach that we need in order to have this concrete discussion on safe motherhood. When we look to how the Ugandan media is perceiving maternal health beyond tragedy headlines, I know that you have read the headlines sometimes screaming, mother bleeds to death at district hospital, woman dies after giving birth on the floor, and these are the stories that spark outrage, but they soon fade away, they disappear, and they leave behind a deep question. Who is accountable? When you look to striking figures, the UN Women's Media Audit 2024 found that less than 20% of voices quoted in health policy stories are women, yet it's women and midwives and community health workers who live these realities every day. So without access to data from the ministries responsible, all the other organizations that help us with the data, or even the Uganda Demographic and Health Survey, these stories remain emotional rather than evidence-based. This data is blinding, meaning that we're missing opportunities and also we are not having the demand to real accountability. So we want to have accountability in this session right here. When we look to the group that I work with, Nation Media Group, in 2024, we ran a series called NTV's Mothers of Hope. It was a mini-series celebrating community midwives who were turning scarcity into service. Then just this year, through our Monitor publication, Daily Monitor, we ran a series also on Budget Watch, Women's Health Edition, and was really connecting parliamentarians' fiscal debates to maternal health outcomes. Then we also had an online platform that was running stories. So where do we go from these stories that cause emotions to our hearts, and how do we fix the narratives that are the realities on ground, from reporting death to demanding delivery? My panelists are going to do exactly that, finding us the fix that we need for today. Allow me to introduce Ms. Judith Mutabazi. She's the Manager, Population Program Coordination at National Planning Authority. She's a population and social development socialist with considerable research interest in areas of fertility, youth, and gender issues, as well as the social determinants of health. Ms. Mutabazi, you're most welcome to the podium. A round of applause for her. We are also trusting Ms. Hadija Nakatude, a midwife at the Department of Reproductive and Child Health, Ministry of Health, to give us a clear picture of what the realities are on ground and what it takes to find these solutions and who's responsible for the solutions. A midwife of that department, she's also a member of the Maternal Perinatal Death Surveillance and Review Secretariat. She's a member of the PPH Steering Committee Secretariat and also serves as the Secretary of the PPH National Self-Motherhood Experts Subcommittee and a trainer of trainers. You're most welcome. We also want to trust that Ms. Grace Namata Saji, the Program Management Specialist of Foreign Commonwealth and Development Office with the British High Commission, is the right person to help us find yet another fix. As a management specialist with over 17 years of experience in program design, program management, procurement, and financial oversight across development as well as humanitarian sectors, she's currently serving with the British High Commission here in Kampala, and she's leading some health programs, including Empower. Then later on, we'll also have the privilege of sitting down and listening to Dr. Fred Muhumuza, who's an economist and a senior lecturer at Makerere University. And his expertise in drawing us the economics behind this session will be very, very important and foundational to the decision that we have to make in this room. Thank you very much. Allow me to start with Ms. Judith Mutabazi from the National Planning Authority. Judith, from a human capital development perspective, we want to find out from you, how is Uganda's national planning framework prioritizing self-motherhood, and exactly what mechanisms currently exist to ensure that non-health sectors, for example, transport and education, budget for their roles?
One of the key results, we intend to reduce teenage pregnancies. We intend to see reduction in maternal mortalities. Some of these indicators, Professor Josephat highlighted them, ensuring there's a reduction in unmet need for family planning, and all this can be achieved in ensuring there's improved population safety and management, and that's what the Human Capital Development Program is advocating for. But also in the National Development Plan, we have taken the program-based approach, which is also contributing to the multi-sectoral approach we are discussing today here. In the program approach, we are looking at sectors are not working in silos, and health cannot work alone. We need Ministry of Gender for community empowerment, literacy issues. We need Ministry of Education to ensure girls stay in school longer. And some of these cases that we are seeing at health centers of miscarriages, maternal deaths, preventable pregnancies can be attained if our girls stay longer in school. And in the NDP4, we are looking at girls staying longer to 11 years, and that is approximately every girl should complete senior 4. And there they are able to make informed choices regarding the number of children they have, the spacing, but also get children at the right age. So all these have been stipulated in the National Development Plan, but we also think they cannot be achieved by Ministry of Health. Every stakeholder has a role. And at national level, of course, we work with Ministry of Finance to ensure resources are allocated to some of these priorities and interventions, but also we work with the districts where they develop district development plans that also guide implementation in the lower structures up to community level.
All right, thank you so much. Please listen attentively to my panelists' submissions, because later on, it's from their submissions that we're going to pick solutions that we want. We're going to be running a fixathon. In this fixathon, we are going to be asking you in this room to help us find a fix that can be multi-sectorial across the bar to find the solution to safer motherhood strategies as of today. Ms. Grace Saji, Allow me to extend a question to you. External aid has been very important, but when you look at the structural shifts that we are seeing in Uganda today, we see that we need to have sustainability in mobilizing our own resources for maternal health. How can we be able to do that?
So we all know that external financing has been very crucial in addressing maternal health in Uganda. We appreciate the funding that has been done through different donor organizations, including the UK government, where I work, and other development partners like UNFPA, the US government, the World Bank, and others, to mention but a few. However, this external financing sometimes come in to address very critical issues like system strengthening and making sure that services reach to those who are in need. But we all know that it's not predictable. And with the current donor landscape, it is very important that as the country we start thinking about how do we ensure that we have predictable domestic financing to ensure that we can allocate resources where they are needed most. So for me, really, it's something that we need to think about. And reading some of the information where the Ministry of Health has been able to secure more funding in this financial year is one of the steps that the country is working towards predictable domestic financing. But my wish or the fix would be for the government to think about allocating a certain percentage, not only in health sector, but also in other sectors that really contribute to maternal health, like we've had education, infrastructure sectors, to ensure that we can actually earmark funding both at national and local government level so that we can deal with the gap that we remain with in terms of predictable domestic financing. Thank you.
All right, thank you so much. I'm glad that you make that comment when we do have the government officials responsible for that in this realm, Ministry of Health, Ministry of Finance. All right, looking to Ms. Hadija, you're the midwife here in this equation. We're looking to multi-sectorial collaboration. You're the one who's on the front line. How does that look like for a mother who is in the labor ward today and now? And what is the single biggest health barrier that you face in helping that mother?
When we speak about multi-sectoral collaboration, as my colleagues have already said, we look at different entities, straight from education, finance, health, bringing resources together to make sure that it does reach the last mile. We also need to understand that there are so many policies that have been formulated, and we can only say that safe motherhood is there unless the policies have really reached the last mile of the mother. So now when you look at the midwifery space, ICM specifically did introduce the midwifery models of care. But for as long as the midwifery models of care do not reach the final woman, there is nothing, we cannot guarantee that is really like safe motherhood. So it is important that policies and also the finance does reach the final woman. But also, when you speak about multi-sectoral collaboration, to the woman who is in labor ward, we are looking at this woman that if it is time for her to be referred, there's a functional ambulance that can take her to the next level of care. The roads are just so clear so that there is easy access to the next level of care. And then there is light. Maybe there is also water that is supposed to be used as they are working on her. But very important from a midwife's perspective is the empowerment of the woman. Because when we speak about the woman, so many times we think that we are speaking about women who are outside this building, but the women are actually us. They are midwives, they are equally, health workers and doctors. So empowering women is very important, as Juliana already spoke about the young girls, that if education does not really do its part, it looks like it is the health system that is going to struggle. For me as a midwife, I've had an opportunity to work in both the education sector and then the health sector, but we noticed that if education does not really equip the health workers with the right skills and the right knowledge, in return it is going to be the health system that is going to suffer, and then that is going to translate into the woman. So it is very, very important that at the service delivery, we have everything that is supposed to be fixed by health. And also not forgetting that women have a very important role to play in this. So communities, empowering the communities, financing is very important, education is important, the parliamentarians, as you have said, and of course the professional bodies, and then the private sector.
The quick fix would be to ensure increased resources to maternal health units. And of course, this goes on all the way from national level to national referral hospitals up to the community health centers to ensure no mother is giving birth in community, but they should be in a health center.
When you say resources, help us break that down. What resources and from where?
The resources, of course, would come in when we set priorities, we allocate resources to ensure these priorities are implemented. The resources are released to implement the plan, and they also go through the whole structure to local governments, and those are the district development plan and then the annual plans, and ensure we also monitor what has been released and what has been implemented. So it's a chain, and all of us, we have a role. The political leaders are accountable, the communities are accountable, individuals are accountable, but also as planners we're accountable, and everyone has a role to ensure there's no mother who is still dying while giving birth.
Okay, all right. Ms. Grace Saji, if you could implement, as one who's very good at strategizing and coming up with programs, if you could implement one immediate financing intervention to save a mother's life, what would it be?
Thank you very much. I think one of the key challenges we've seen stock out of supplies that could lead to the dangers that mothers face. So we need to fix that, and if I was to be given an opportunity, is to make sure that we invest in a very good digital procurement system and supplies management to ensure that commodities reach where they need to reach on time, so that will remove wastage and inefficiencies. And also to make good use of the digital tools like artificial intelligence that we've all talked about this morning, and ensure that, you know, we use these tools to enable us predict the shortages and make sure that the supply chain can address these shortages of stockouts at different health centers. Thank you.
All right, that could actually work. Most recently, the president was campaigning in northern Uganda, and he said that he's going to recruit his own team that will do ground supervision to ensure that there's no drug stockout in hospitals. That shouldn't be the case in this day and era, when you do have national medical stores also having recently launched a nationwide campaign just to ensure that there's no drug theft and drug stockout in hospitals. So that definitely would be a good fix. All right, then we also want to listen to the midwife on our panel. Dear midwife, when it comes to solutions, what do you believe is the most immediate quick fix that we can adopt now, between now and next year same time, to save 1,000 mothers?
I'm pretty sure many people have predicted what my answer is, but my quick fix would be more midwives, and more midwives. In fact, as the midwives who are here know, that ICM is running a campaign for 1 million midwives. So to me, I feel it is a quick fix, because midwives are at the service points, they are at the antenatal spaces, they are next right with the woman. Midwives are actually everywhere. So for me, if I am given the money right now, I would recruit more midwives. But of course, because of multi-sectoral collaboration, midwives don't work alone. So ensuring 24/7 staffing of also the other critical cadres is very important. But of course, the fix still stands. I would recruit more midwives.
1 million midwives. 1 million midwives. How possible is that? That's a multi-sectorial approach fix. Because the Ministry of Health will want them, then finance will tell them we can't afford to have all of them in 1 year. Then public service will also have to look through that. There's a lot of stakeholders involved in the 1 million midwives, but it is possible, right?
1 million is across the whole entire world.
Yeah, yes. All right, okay. All right, Lunguzi, you have been across Africa, you've been able to look at these matters from a different African countries' perspective. What have you found to be the most immediate effective strategy that can be adopted to save 1,000 mothers in 1 year?
I'll go with Khadija, more midwives. Not only midwives, but competent midwives. Competent midwives, one who not only look at the clinical side, they know what they are doing, but they should also be able to reach out to the community. A community must know that there's a midwife here. Juliana is a midwife. They can go to her home. Juliana can go to their homes. Juliana can go to the schools as a midwife. So I want not only a midwife, but a midwife who is mobile, a midwife who is competent, a midwife who is known, a midwife who has the loud voice to provide that package of MNCH. Midwives.
All right, so that means that we have to also increase on education when it comes to midwives, extend more schools or allow opening up of more institutions that can train more people to become midwives in order to address that. The mobility issue is also another thing that you have talked about. I remember the Prime Minister, Rebecca Nabanja, when she was in the Buganda region, traversing one of those districts, in Nakasongola to be exact, she found out that there are no midwives, and so mothers there are suffering while giving birth, ending up losing children or even their own lives, simply because there is another traditional midwife that is doing the job. But because they don't have the clinical and medicinal approach to it, there's a life or lives that are lost in that line.
Apologies for that kind of change. We felt our chief guest will be here in 10 minutes or 7 thereabout, but we felt we should utilize some of this time to move the process a little quicker in the interest of time. In maternal and child health, we handle emergencies. I want to begin by once again adding to my Director General that we are all very welcome as a community of practice, as a community for maternal and child health. This is really warm. I can see the overflow, and also in the lower auditorium, we are really, really very impressed that you honored our invitation to come for this annual convergence where we listen to each other and we learn to improve the care. My role this morning is to present to you what we've been able to collectively gain as a team, and as the theme goes, that this has been a multi-sectoral effort. We cannot attribute all this success to one individual. We cannot attribute this to a single organization, and even to government alone, but we've been able to deliver this as a multi-sectoral team. I also want in a special way to thank the organizers, the secretariat behind this 5th Safe Motherhood Conference. And I hope the team that's working on the link for PS listening is also working on that. So once again, thank you very much. I'll walk through these slides. They highlight, yes. I want to begin by acknowledging that this has been a collective journey, and you can see the multi-sectoral outlook, the civil society organizations and communities, the private sector, the faith-based organizations, the media, academia and research, the implementation and technical partners, development partners in the house, government departments, agencies, and the local government. I want to begin with leadership, that we've been privileged as the community or the space of maternal and child health, that we've had a lot of support from high-level supervision from the Ministry of Health, which has really helped us a lot to strengthen leadership and governance at the subnational level and also at facility level. I also want to mention, as an innovative approach, we've been conducting weekly maternal and perinatal death reviews, a practice that is attended by more than 1,000 participants twice every week to foster peer learning and response to follow up to ensure that we strengthen the modifiable gaps at subnational level. We also want to note that the National Safe Motherhood Experts Committees, PPH, PET, and Safe Birth, have done a commendable job in enlightening the communities through awareness campaigns, which are done throughout the year, and this has really been very powerful at enlightening our communities. We've also been able to implement the multisectoral platform, Teenage Pregnancy Surveillance and Response. As we all know, Uganda is still burdened by a high teenage pregnancy rate of around 25% for the last 20 years. And this needs a multisectoral approach, and we've been doing this multisectoral approach. And as a matter of fact, yesterday, we had a pre-youth, pre-adolescent conference event here at the same venue, and we shall come up with resolutions from that meeting at the end of this conference, and we see what kind of support we need to reduce the teenage pregnancy. We have a very vibrant national platform, RAMNAC Technical Working Group, that meets every month to discuss issues and resource mobilization, and this also works as a platform, a country platform for the global GFF, Global Financing Facility. I'm happy to note that Dr. Murindwa Grace is here to represent the World Bank. We have sustained performance of the regional accountability platforms at subnational level, at regional level, called the local maternity and neonatal systems. These platforms have really addressed the local problems using local solutions. We agree and we are cognizant that there are variations in terms of problems and solutions. So the local maternity and neonatal systems provide tailored solutions to local problems in the different contexts. We have so far 16 active local maternity and neonatal systems. And I want to appreciate with an applause the local maternity and neonatal system coordinators who are here in the house. Wherever you are greatly recognized. You're doing an incredible job for this country. We want also in a special way to appreciate the chief administrative officers. They are part of the local maternity and neonatal system. The RDCs, the DHOs, they have not missed my phone calls because systems must improve. Everyone must be accountable if we are to save or to end preventable maternal and newborn death. But in a special way, the cow of Kayunga, I want to recognize the cow of Kayunga, who interdicted 4 doctors on a single sitting for failing to attend to duty for chronic absenteeism. That is accountability. I would have done the same. Please, for our health workers, if you don't attend to your duties, then there are people out there who are saying you must account. Similarly, the cow of Kakumiro, who recruited all the critical staff. I don't know where he got the money, but he recruited all the critical staff needed for his health facilities, and Kakumiro is one of the best performing facilities. I hope they will be recognized at the dinner. Cross-country exchanges, we've been able to impact beyond Uganda. We had a visiting team from Kenya late last year, and they learned how we are doing accountability for results. We told them that Kenya is a richer country than Uganda, but we had better results than them. Since then, Kenya has started 6 months ago, and right now, they are doing very well in MPDSR. One of the regions called Homa Bay has gone 6 months without a maternal death. They are very impressed about their experience. We also hosted Ethiopia to come and learn from Uganda. We also hosted Zambia in the year under review. They are all learning about the exemplary leadership and our structure. Service delivery, the reason why we're here. There's been remarkable gains in service delivery. We conducted an EMOC, Emergency Obstetric and Newborn Care Needs Assessment, that informed our targeted interventions, enabling 78% of the health center force to offer CMOC facilities. That's an incredible achievement. 27 health center tools, mostly in refugee hosting districts, were upgraded in the year under review to health center 3s, and 11 health center tools refurbished for readiness. Emergency call centers established and functionalized in those places. 9 high dependency units established at different regional referrals and health center 4s. High risk pregnancy clinics, the only country probably, I don't know, in Africa that's implementing this intervention without even WHO guidance, and it's moving us miles. We're identifying any lady, any pregnant mother with a risk, following them up, retaining them in care, and linking them to appropriate care through a birth response plan. A birth planning, and these mothers are being saved. I want to thank the primary service providers, the frontliners, the midwives. They are at the top of this. This is going to deliver us to 2030. Uganda will post a very good results if we implemented this to scale. Uganda Blood Transfusion Services has increased collection to 393,000 units, 68% growth since 2002. And we have not lost mothers because of lack of blood. Can we give that a hand clap? And still on blood transfusion, we believe in functional ecosystems. When you move a patient from one ecosystem to another ecosystem of care, you get a lot of delays. We have instituted an intervention where we move the blood, not the patient. And this is being piloted in the Elgon local maternity and neonatal system. Dr. Bumba, the head of the blood transfusion, is in this house. He's been very supportive. We move the blood, not the patient. That is a Ugandan-made solution. We have saved so many. Doctor, get to the theater, ectopic pregnancy, we shall get you the blood there. I want in a special way also to thank National Medical Stores, Medicine Commodities and Supplies, DG and the team. Despite the funding disruptions, Uganda's emergency kit for drugs and supplies for the last 6 months has been very stable, very stable. We have all the critical supplies, and I've been asking the ADHOs, if you know you don't have, please get to us. But also in a special way, I want to say that we've introduced new commodities. There's a commodity in that list called heat-stable carbetocin. Heat-stable carbetocin is a magical drug where you don't have a functional cold chain. Some of our places are in hot areas, so we need such new molecules to help us. Heat-stable carbetocin does not need refrigeration. It can be kept under normal room temperature. We also introduced tranexamic acid, a drug that stops bleeding. And our dear health workers, this is a very strong message for TBAs, mothers who still want to deliver under TBAs, traditional birth attendants. They do not have these commodities. In this special way, I want to recognize UNFPA for supporting the purchase of the first 20,000 units of heat-stable carbetocin. I also got good news that UNICEF will support us with 2 million doses of heat-stable carbetocin next year. That covers the entire number of pregnant women. So heat-stable carbetocin is going to be for prevention of PPH, and oxytocin will be for management of PPH. 70 operating theaters supported with new equipment, and this was with money from the World Bank, UCREB, the coordinator is in the house, 40 of which received a complete set, and you'll see how we functionalized theaters over the last 1 year. Digital blood stock dashboard. If you've not seen it, someone will show it to you. Every day in Uganda, we have a stock status. There's a young man called Innocent Kananura who posts the stock status. Even today, I know how much blood is in Arua, which type, and that is available for every health worker through their local maternity and neonatal system. Kananura, if you're in the house, thank you so much, and the leadership of Uganda Blood Transfusion. Neonatal care equipment, caffeine citrate, was introduced in 20 NICUs. CPAP expanded more facilities, and family planning redistribution, commodity redistribution by Maristops. After the closure of the USID, we had a lot of stocks of family planning commodities at joint medical stores. And we want to appreciate Maristops and UNFPA for coming in and distributing them. We didn't have the money to distribute them to. Thank you so much, Maristop. Under human resources, I'm very impressed that the vote for midwives has gone through. We lack the numbers. That is a good club. Our partners here, we lack the numbers. We are doing everything possible to ensure that we move to the 2030 high table. But the numbers need. Over 1,200 health workers have been trained in ICD-11. This is medical certification of death. 90 in neonatal resuscitation with the help of ELMA and SEED Global Health. And we are going to train more, 200, I think, this month. NASU will make webinars every month to address gaps in management of PPH, PET, prematurity, and sepsis. Continuous mentorship in CIMOC, Safe Motherhood, KMC, and ITO have been conducted. Districts have recruited critical cadres. I got a very nice message last night from Tororo where they are lacking an anesthetic officer, and I got a confirmation of an appointment that we now have anesthetic officers in Tororo, Mulanda Health Center 4. The Corporate Society of Safe Motherhood, my DG had mentioned about it. This is an innovative way of raising local financing. At the beginning of this year, we had 81 million Uganda shillings. And I'm one of the signatories to that account, but it's managed by Stanbic Bank. Stanbic Bank is one of the signatories. We have some money to respond to emergencies. We have bought autoclaves for Bushenyi, Lalogi, Nomoro, and many other facilities on emergency request. So because the government procurement system is bureaucratic by design, so sometimes we need to address emergencies head-on. So we've been able to procure this using our locally mobilized fund. My call here is support this initiative with the small amount you can. Stanbic is the one holding this fund, but also in a special way, we've been able to attract partners who have been with us for the last 5 years, like Bank of Uganda. I'm happy Susan is here and Sarah, and they are going to make a statement on how much they've invested. They will tell us what to do so that they add us more money. UNFPA has given us matched financing. If government commits funding, they also commit funding. We are so proud of this initiative as a sustainable way of mobilizing domestic resources. Parliamentary engagement has also been at the top. Unfortunately, we don't have any, I don't know if there's any politician here, but today, all our ministers are being nominated today, but my friend and elder Kenneth is the minister today, the non-political minister. So we have not been able to get members of parliament. They are fully behind this, and they really appreciate the strides that we are making collectively. Performance linked to UGIFT grants, strengthened facility level accountability and ownership. This is the RBF. It's a magic bullet. Hard work, more money. You work more, you get more money. I think this is a revolutionary financing intervention. It has led to improvements at facility level. It's one way of doing it. We continue to, next. Performance across MNCH. If the chief guest comes, you'll alert me, because I've got to stop. So performance across the key MNCH indicators. The data source is the UDHS. We preferred using the demographic, no, this is District Health Information System 2. My apologies, some of the figures might not look exactly similar to what we have in the survey, the UDHS, the Uganda Demographic Survey. The reason is I'm giving accountability for the year under review, 2024, 25. The survey is done every 5 years. Can we move? I started with family planning. As I earlier mentioned, family planning is a critical pillar of safe motherhood. And I'm very happy that we have religious leaders in the house who have been very supportive to family planning, like our dear Reverend Amos Magezi, who is here in the house. Kindly stand up for recognition and send our appreciation to the Most Reverend, the Archbishop of Uganda. He's a family planning champion. Family planning colleagues, we must repackage our messages. It's not about sterilizing women. It's about healthy child spacing. It's about getting babies by choice, not by chance. It's about giving a woman an opportunity to prepare for a pregnancy. It's about ending unmet need for family planning. Now, this is the science. With 4 million that figure, 4 million couple years of protection, we've been able to avert 1.2 million pregnancies. There is a calculation behind that. That the more couple years of protection you have, like you're protected, women can potentially get pregnant anytime. We all know that. So with 4 million couple years of protection, CYP's couple years of protection, you are able to avert 1.2 million pregnancies, unwanted pregnancies. And remember that 42% of the pregnancies in Uganda are still unintended. That is a pregnancy by chance, not planned. I don't want to call them unwanted because I may be part of that. That's a commercial break. So I'll get some serious beatings. So this is family planning. We have had a steady supply of our commodities, and I can guarantee the country that we have the next supplies for the next 6 months. And thank you, UNFPA. You've been part of this journey. Thank you, UNFPA. I can see Daniel here. I know you will say we need more money, but money is coming. Next. Next. This is also the science that we have all the methods. We have all the methods. We have all the methods available in Uganda. No one should say that we lack this, at service delivery points. But also in the footnotes that about 30% of our women are using long-acting reversible contraceptive methods, like the implants. Long-acting but reversible. They are good because they give you more couple years of protection. The most utilized method is Cyanopress, the injection for 3 months. And we have enough stock. Actually, we recently donated to some country through Daniel. Next. The trends in uptake of immediate postpartum family planning, this is commendable. This is commendable, and thank you, our service providers. We are seeing a very healthy trend. We are moving upwards, and this is a very healthy trend. 44% increase in uptake over the financial year under review. There were regional gains in Ulango, Bugisu, Bukedia, Karamoja, and Kampala. Well done, teams. Next. Move a little faster. This is an illustration of how the different regions performed. I told you under the local maternity and neonatal system, but important to note that post-abortion family planning, for any woman who loses a pregnancy, spontaneous or whatever, she needs family planning method as part of the package. Improved uptake, we noticed that there's higher uptake in those regions. Adolescents contribute to 15% of the total post-abortion. For the religious leaders in this community, there are abortions under adolescents. I know we are burying our heads under the sand, but the young people are aborting. Young people are aborting, and that's something that we must tackle head on. Next. Antenatal care. Next. Oh, the PS doesn't like this. Let's go back a little. This stethoscope, you can see how it's pressing on that lady's tummy. We want to abolish them. We have procured 2,000. We have procured and distributed 2,000 fetal Dopplers. And our intention is next year, this one is going home. Next. It's going in the archives. We have seen a progressive increase. There are major changes in women attending ANC1. Our aspiration is to have every pregnant woman attend antenatal in the first 3 months. At least the first antenatal visit should be in the first 3 months. We still struggle with this. I don't know if the reason is cultural. We have our cultural leaders, but we need to talk to the women. The package that defines whether you're going to have a healthy baby or not a healthy baby is in the first trimester. The test for the 3 diseases that we're targeting for elimination, and health workers kindly package this better. We need to eliminate HIV, we need to eliminate hepatitis, we need to eliminate syphilis. They are all tested in the first trimester. The development of a baby happens in the first trimester. That's the first 3 months. If we don't fix the problems that are in there, then we can get any potential problem on the baby after that. So I think we need to repackage. Women can listen to this message better, but we need women to come to the health facility in the first 3 months of getting pregnant. As you can see, the performance is not good. We have a national, this year we improved a little to 40, but compared to the 2 million women who come in the first time, all of them are untimely. I know there is no push in women coming faster, but this is critical. Next. This is just a description of the regional variations, and you can see red is Kampala. Kampala, someone will need to talk specifically about Kampala. The place with the most elite people, the place with the most number of health facilities, but we also notice that Kampala has a big challenge of access. Financial barriers might prevent people from accessing. So more women in the regions of Lango. We need to learn from Lango and Bugisu. Bunyoro, Toro, and South Buganda and North Buganda remain the lowest with 35. NC8 attendance remains low across all regions. Next. These are teenage pregnancies. I earlier mentioned that we are battling with them, and the battle continues. So there is a special multi-sectoral approach involving the Ministry of Education, Gender, and the Health that sit regularly through a platform of permanent secretaries and also the technical people. And we are estimating that probably 1,000 adolescents, this statistic is from the Division of Adolescent Health, are getting pregnant daily. After this, you'll see Irene. Thank you very much. Next. Trends in uptake of ANC interventions. During antenatal care, there is a very nice package that the healthcare workers provide to our mothers. So we are happy to have all the interventions in green. Where you find green is not DP, but that means we are doing well. Where you find yellow is not NRM, that means we are moderate. Red is not NOP. So, red, we are focusing on the red. I know we shall have breakaway sessions. We are focusing on the red. We have consistently had a poor screening for hemoglobin. We are not measuring women who are pregnant for their hemoglobin level. 28% for last year. It's an improvement from 22, but not good enough. We want that in green. The Ministry of Health has done something. We've procured hemoglobinometers, the machines that can do that. I was talking to the Commission of Laboratories. We shall probably have more, 2,000 coming into circulation. Whoever doesn't have, through your LNMS, let us know. HB, hepatitis B screening is also in red, has changed from red to yellow. We still have work to do. Obstetric ultrasound scan. Every pregnant woman before 20 weeks of gestation should have a scan. We stand at 28%, only Kampala probably. On average, a scan costs 20,000 in the village. The women cannot afford. We have a program that we launched yesterday, and I think we are going to be very intentional, Chief Guest and Minister, that we are going to be intentional in providing points of care ultrasound scans next year. I'm happy the project highlights that. So the rest of the details are in the report that we are going to launch, and each one of you will receive a copy. Next, we move a little faster. This is the geography, the distribution. We are using data optimally to see who is letting us down. So I think you can see the reds. I'm not even able to see very well, but I think you can see the reds. Or what I can see is fourth ANC has more reds and fewer greens, but the first, at least one antenatal visit. Women in Uganda are attending at least one antenatal visit. We've achieved universal health coverage by 97%. At least one health visit, 97%. 4, 68%. Next. Maternity. We got permission from those people there, so don't worry. So, the trends in health facility delivery. I wanted to put a disclaimer here. Whereas the survey gives us 86%, our annual review, this doesn't mean it's a drop, but there are some facilities that are not reporting on time. We see a progressive increase. As you can see now, we stand at 71% for the financial year 2024. We clap for the midwives. In terms of absolute numbers, these are 1.6 million babies. 71% is equal to 1.6 million babies conducted by our midwives in the last financial year. And the comment is there is a significant improvement towards achieving the national target, which is around 74%, but we are going to increase it today. 11% increase from the last 2 financial years. Progress everywhere. I'm so proud of you guys. We are reporting progress. Next. This is something that you'll find in the report, but majority of the deliveries have consistently happened at Health Center 3s. If we have any people from the Health Center 3s and the ADHOs, please we clap for them. By ownership, most of the women are delivering in government facilities, 83%. 13% in PNFPs, and 4% in the private care. 83% of the 1.6 deliveries are happening in government facilities. You are doing an incredible job. Deliveries in public health facilities has increased by 100. That's an absolute number. Next, you'll see the breakdown later. This is an interesting slide. One of the resolutions last year was to embark on functionalizing health center force and trying to bring those lines as close as possible. You see, last year, we had only 66% of our health facilities were providing blood transfusion, was providing cesarean section and blood transfusion. Incredible progress. Working with UBTS, now we have, those lines are getting closer. We have 78% of our CMOC facilities able to provide cesarean section and blood transfusion. And I'll show you the graph. Over 80% performing cesarean sections, nearly 80% providing both surgery and blood transfusion. Great progress. Increased capacity to provide cesarean section and blood services by 18% increase, overall 24% among the public health facilities. The gaps remain in blood supply. We need everyone. I know Charlotte is here. She's a champion for mobilizing for blood. And remain infrastructure and skilled staffing, limiting effective emergency obstetric care. Next. Postnatal. Next. This is a graphic illustration. We are able to granulate our performance per region. I want to encourage each of us, especially the DHOs and AGOs who are here, to get interested, especially in the reds, that we must eliminate red and move to yellow and green. PNC coverage is high at 96% within 24 hours. That is the 6 hours. But drops 36% at 6 days and 55% at 6 weeks. Considering consistently South Uganda is where we have areas like Kalangala, Greater Masaka. I hope I've got it right. South Uganda is Greater Masaka, and that's why our chief guest, I'll get a way of packaging this for her. We need to work with the cultural system to ensure that these indicators in South Uganda really improve, especially uptake. And Toro, since I'm also a minister, I'll take that one myself. West Nile, I think we shall give it to Baku, Chandia. Need to draw lessons from good performance from Acholi and Ankole at 6 weeks. Amazing performance. 6 weeks is a missed opportunity. 6 weeks is a health service milestone. It's the first time the baby is brought for immunization. We want that to be 100%. That means babies are brought for immunization, but they are missing out on, mothers are missing out on PNC. Our service providers, we can do more here. Next. Our trends in PNC missed opportunities. This is a slide where our service providers need to focus. We are really missing an opportunity where a mother comes with the baby and we are not attending to them. And that's what is bringing on. We are going to move down and ensure that there is proper integration. Next. The baby, the newborn, the voiceless, they are here. And as a preamble, this is one indicator that has not improved significantly for the last 20 years. But next year, the next 5 years, we are going to go massive on newborn care. We lose so many babies. Next. This is a show of the prevalence of low birth weight and initiation of KMC. Any baby born with less than 2.5 kilogram is considered low birth weight. And those who are less than 1.5, very low birth weight. The lower the age, the more the complications, the more the problems. The more the problems, the fewer the chances of survival. And we need a health system that is responsive. So the prevalence of low birth weight is still at 5.2 of the live birth, up from 50% babies with low birth weight are at term. 50% of the babies with low birth weight are actually 9 months. Are 9 months old, but this is a nutrition problem. And recently, DG, we went to Kabale. Kabale has the highest, despite being a food basket. They have the highest number of preterms, the highest number of low birth weights during the regional conference. So we need targeted interventions to address some of these. The proportion of live babies with birth asphyxia. Birth asphyxia is difficult in breathing at birth. This table illustrates that we are making progress, and there has been a deliberate intention to train health workers, and you can see successful resuscitation is at 92%. We appreciate you for picking these lessons very well. We need to prevent and manage obstructive labor, scale up CPAP, continuous positive pressure in labor wards, improve provider skills. All these are areas of investment, and they need some resources if we are to have everything set for the newborn. Our investment for the newborn has been suboptimal, but we need to have a focused attention for their survival. Next. This will be found in your report. You'll look at the regional distribution, but it highlights the proportion of babies with birth asphyxia. You realize that most of them are the higher centers of care. We are a bit happy of this, but we need to find out why. Is it because of the high numbers, the higher levels of care, the health center force, the general hospital, and the highest being the national referral hospitals? It could be because of a functional referral system, but also because there are so many cases and there are delays within the institutions. The clinical services will work with us and we see how we can fix this. Notable decline in birth asphyxia rate. This is good news. General and regional referral hospitals have reduced about 5 to 6% in the last financial year. Babies born with birth asphyxia successfully resuscitated. Next. Child health. We have intentionally brought child health. This is the first time we are giving a State of the Nation MCH. Last year we gave only MPDSR, but we felt that there was need to expand and give the larger scope, and this is child health. Immunization is making good progress. Next. And we've introduced a couple of vaccines. Immunization coverage, you can see this is progress, and we shall avail this in your reports. The report is available. But in conclusion, immunization coverage continued to perform well, maintaining levels above 90% of the targeted key antigen. This is massive. I wish we can do the same for malaria vaccine that we've recently introduced so that we can protect our children. That will be the future of this country. Next. Fully immunized by 1 year, we will also find it in your reports. Immunization coverage continued to perform well, maintaining levels above 90% of the key antigens, as you can see. Next. The prevalence of the top 5 childhood diseases in OPD, the childhood morbidity remained concentrated among preventable conditions, with cough, malaria, and diarrhea accounting for the most outpatient visits. These are the conditions that are disturbing our children, and we think we can do a lot because they are preventable. Next. Mortality. Now, this is the MPDSR report that we've been having over the years. We are very intentional at counting the dead. Not that it's the best thing to do, but this year we've also been able to estimate the case fatality. And Professor Pius must be happy because we talked about this. And we've also started operational research on following up near misses, those who were almost dead, who survived a life-threatening complication. So institutional perinatal mortality. Our story of counting started in 2016-17. That's a beautiful graph that we need to clap for, and we stand at 15.4. As of today, we stand at 15.4 of our institutional mortality, institutional perinatal mortality. A very key indicator of how responsive our health services are. And we really want to appreciate the healthcare workers and all of us, the stakeholders, for this. The highest decline was among the fresh stillbirth, 31%. As we all know, fresh stillbirth is a measure of quality of intrapartum care. We have deliberately invested, we have trained, and DG, we have improved intrapartum care. 31% decline of fresh stillbirth. We want to take that one to zero. We want to take that one to zero and indicating improvement in the quality of intrapartum care. Next. This, you'll find it in your report book. It's available, but it shows the regional variations. But importantly, we need to flag off the red. Bukedi, that's the Greater Elgon. I hope Kampala is still part of this. Kampala has problems. Kampala, Karamoja, the reds, you'll see in the report. Next. Now, these are trends in the national perinatal death notifications. As I earlier mentioned, we have a very robust program, one that countries in the world are benchmarking of perinatal death review and maternal death review. Most of the notifiable deaths are being reviewed, and we are proud of this. But the graph shows where we've come from. We came from 1.5% reviews. We now stand at, I can't see, I think 56, thereabout. We now stand at, from 1.5 probably 10 years ago to 56. Commendable work. Over 2/3 of the regions met the greater than 50% target. We thank you. Kampala, Busoga, South Buganda, Teso, and Toro still need support for improvement. Next. This you'll be finding in your report. It shows the perinatal death reviewed by type and birth weight. We are so detailed, but in summary, 54% of the perinatal death were greater than 2.5 kilograms. We don't expect a baby greater than 2.5 kilograms to die because those ones don't have a lot of complications. These ones, we must address the gaps. Next. Causes of early neonatal death over the last 5 years. As we mentioned, we have had a decrease in birth asphyxia. We are registering decreases in everything, but we still have work to do. And that is really significant. So you'll read in your report. So the report is quite detailed, and for those who love reading, but those who don't love reading, next, it's a problem. But we shall put it in soft copy. Decision to incision interval. We have moved from measuring these things of patograph use, dear health workers, because you feel them after birth. You feel them retrospectively. Some are religious, they feel them religiously. But some of you feel them after birth. We are going to measure, we are going to be intentional. DG, you alert me, since you are my friend. Okay. We are going to be intentional in measuring the decision to incision time. Emma, that means I stop? Okay, continue. We are intentional in measuring the decision incision time. When the chief guest comes in, I will request that we stand up. I will also stop, and then we go into the protocol. I will come in and complete. The decision to incision interval, 2024. Commendable work. Thank you, the doctors. Thank you, the service providers. We are seeing a decrease in the time it takes for a mother to receive an intervention. Most outcomes of fresh stillbirth were operated within 30 to 60 minutes. We want to reduce that to less than 30 minutes. We need to make sure that the system is ready, our facilities are ready, the critical human resources are available, and I hope we have consensus on this and we shall be able to improve. Next. Pregnant women, mortality. My most favorite, and I want to be remembered as a champion for mothers. Thank you, thank you. Mortality, institution, and maternal death. Next. Amazing journey, and I want us to clap for the healthcare workers. You see where we stand? There has been a sudden drop in institutional death from 83 per 100,000 to 69 per 100,000, and this is commendable. 25% reduction. It's a 25% reduction in 1 year across, 25% reduction across the 5 years. We started at 109, it was not 100, 109 per 100,000, and we have moved steadily. Where you see 90.3, that was the time of COVID, there was system disruption. But at this rate, I think with all of us energized, success has so many fathers and grandfathers, we shall be able to achieve. If we increase it, I've been told that we need to double, we need to reduce the mortality by 13.5. We are currently 13.5%, we are currently reducing at 7.9. This will lead us to the SDG target of less than 70%. 16% reduction in IMR last 2 financial years, 23% reduction in IMNR in the last 3 years. You read this in the detailed report. Next. This is our regional show. And allow me on this case to single out Bunyoro. Bunyoro has been problematic for the last 5 years. Bunyoro, if it needed a standing ovation, I would stand for you. Look at Bunyoro, Dr. Bwaga and your team, Team Bunyoro, coming from 114 in 2021-22, and you are now at 67 per 100,000. This is the most market reduction. Thank you so much, Bunyoro. We have a project coming in Bunyoro. We think you'll even do much, much better. The problems are still in Kampala. Kampala, you can see. We shall granulate Kampala and describe it very well. And we really want to thank you. 69.1 institutional mortality is unprecedented. Next. Who is dying? We've been very critical in knowing who exactly is dying. The mothers who are dying most, you can see the different years. We've reviewed 3 years. IMR declined across all age groups. Adolescents account for 1 in every 10 maternal deaths. 10% of those who are dying are young people. They are not supposed to be pregnant. They're supposed to be in school, but you're dying. So we need to do something about them. But also see that the age group that's dying most remains above 25 years, and the number 1 killer is postpartum hemorrhage. Next. Trends in maternal death notification. 15% increase in notification rate over the past 5 years. Very commendable work. And you can see we are rotating in the highest levels. And, but there has been a slight decrease. Colleagues, let's get back to work. Tuko na kazi. 19.6 increase in reviews. Commendable work. Next. This is the distribution of institutional maternal mortalities. I want to report that 56% of all districts reviewed more than 95% of the reported maternal death. Every death in Uganda is audited, it's reviewed, and we must know what killed the mother. 6 districts named below failed to review or capture any of their reported maternal death. Must wake up. Bokedia, Botebo, Isinjiro, Nakasongola. Please work on that. 23 districts did not report any maternal death. And I want to single out Adjumani. Adjumani had gone 4 years without a maternal death. Adjumani, I don't know the magic they do. Thank you, DHO Adjumani. I don't know the magic in Adjumani. I need to come and see. But Adjumani had gone 4 years. They recently got a maternal death. They all kept crying the whole day. I want to stop and we make a standing ovation for the grand entrance of our chief guest. And please feel free to stretch a little bit. It's part of our self-care. I can see Dr. Biaruhanga. Self-care, take water and stretch a little bit as we welcome our chief guest. And immediately, my friend Emmanuel will guide us into the protocol of anthems and all the others that will follow. I think we can welcome her with a hand clap, our chief guest, Her Royal Highness, the Nabagereka. Sylvia Najinda, you're most welcome. It's a privilege to host you at the 5th National Safe Motherhood Conference. As a mother, as a champion of the young people, as appropriate and thank you. After the drama, we shall have the anthems.
Thank you, thank you, thank you.
I think we can first take our seats.
Thank you.
Let's first take our seats. Let's take our seats because let's first handle this in honor of our guests of honor.
Thank you, thank you, thank you. The drama team, thank you. Thank you. A round of applause to the drama team. We may all rise for the anthems.
We are happy to have you here, and thank you very much for allowing to be with us as our chief guest. And we appreciate all the work that you've done for Safe Motherhood. So we had started on giving the State of the Nation maternal, newborn, and child health presentation that had moved halfway. And importantly, about this conference, this is the 5th consecutive Safe Motherhood Conference that we strongly believe you are part of this community because we know the great work that you are doing in the Uganda Kingdom and internationally, especially your work around the Chisakati. Especially, I think it deserves a clap. Madam Chief Guest, that, Your Royal Highness, that is a model intervention that we feel we have seen, and we really think that it's very transformative for the young girls, especially in this era where Uganda still struggles with very high numbers of teenage pregnancies. We request that you extend the same message to the other kingdoms and the other queens in the other kingdoms so that we can protect our young girls. 24%, one in every four pregnant women is a young girl. And also 25% of the maternal mortalities are happening in the age group 15 years to 25 years. Not very good statistics. And we think that the country loses a lot by having these young people have these difficulties. Madam, Her Royal Highness, the Chief Guest, allow me also to mention that yesterday we had a young people. You might be shocked there are not many young people here. Yesterday we had a pre-conference event for young people and the youth. We specifically have one special day for them because of their uniqueness in terms of their needs. They come here, we pick them from different parts of the country with the support of our partners. We bring them in a central place and we discuss their issues and how we can mitigate some of their issues. We have noticed outside teenage pregnancies, there's also an increasing number of substance abuse among young people. And this is for all of us in this house. They will be here on the final day. A representative of young people will be here on the final day to represent them and provide their resolutions from yesterday's meeting. This is the broader way. Your Royal Highness, the theme of this conference is to make safe motherhood everyone's business. It's a multi-sectoral business. Saving women and ensuring they are surviving and thriving is everyone's business. So with those remarks, I felt I should give that background, and we continuously move in this kind of way to ensure that Uganda has a very ambitious target of ending preventable maternal and newborn death by the year 2030. We want to be at the high table where the UN target is 70 per 100,000 live births, but for us we're at 189, and we think we can make it. And this is where I was with the presentation, and I will request that I complete it, then we go to the other agenda items. Can we just go a little bit on the mortality? Yes. Your Royal Highness, Uganda is a very fertile country. We have approximately 2 million pregnancies a year, though we deliver around 1.6 in health facilities, but the total number of pregnancies is around 2 million. We want, our aspiration as service providers is every woman in this country to give birth to the number of children she or the couple wants, not by accident, but by choice, and also to be able to plan very well for their families so that we get a very productive population that will deliver the Uganda Vision 2040. Those were regional variations I had earlier mentioned, and we shall reach your office because we need your support, that we notice South Uganda and North Uganda and Kampala have been having very poor indicators across the board for newborn, for maternal, and for child health. So we are going to work with your foundation to ensure that we carry a message that's very strong to ensure that we save mothers and the newborns. Antenatal care, and are also still challenges. Next. This slide was speaking to who is dying. We've been able to analyze our data, and we do this on an annual basis, but we also do this on a weekly basis, so that at the end of the year, we granulate and present. So overall, we have noted a decline in IMMR, which is institutional maternal mortality across all age groups. Institutional death means that either the mothers are delaying in the community, they are delaying to reach the health facility, or they are delays within the facility. Those 3 Ds can cause a mother to die: a delay in the community, which is within the means of our other players outside the health system, the delay to reach the health facility, a broken bridge, a poor road, lack of transport is delay number 2, and delay number 3 is the delay within the health facility, absent health worker, inadequate equipment, inadequate commodities. So we have done so well to improve on availability of commodities and equipment, and we still continue to do a lot, and that's why we are seeing a decline in institutional maternal mortality. We still have work to do, and this year we celebrate a 69 or close to 70 per 100,000 deliveries institutional maternal mortality. Next slide. We're intentional in knowing that every mother who dies, wherever they die from, we get a notification, and every mother who is notified is reviewed. The best case scenario would be to have both of those lines. If it's 100% notified, 100% is reviewed. So we also need to know 100% dead, because we have introduced a community system where the communities are going to report. If the healthcare workers are not reporting some of the maternal death, the communities will report them. We have community health extension workers, and my colleague, Dr. Richard Kavanda, who is one of the subjects in Buganda Kingdom, is here with us. He's spearheading the community health extension program that is very strong on reporting and enlightening our communities at that level. So the best case scenario here is both of them, same number notified, same number reviewed. We are moving those lines closer, and we did so well last financial year, despite the slight drop. Next. Our dear participants, we still have areas of pain. As you can see, institutional maternal mortality reported. You can see where we have red. Red is, those are districts that are really still have concerns, and we need to support them intentionally. Our team is going to support those districts. Isingiro, Namusindwa, and the like as highlighted. The details of this are in the big report, and I beg to continue to the other one. Next slide, move a little faster. The leading cause of the maternal mortality over the last 5 years. the women who are dying, what is killing them. So through our audits, very comprehensive audits, and where the health workers don't do comprehensive audits, we actually conduct confidential inquiries. Confidential inquiries are constituted by a team from Ministry of Health and the local maternity and neonatal system. We come in, if you don't audit yourself well, we come in and help you and audit you. So we do audits of these maternal deaths, and we have found that continuously bleeding from after childbirth, before and after childbirth, which we call obstetric hemorrhage, has remained the leading cause of maternal death with 40 to 46%. This is followed by hypertensive disorders that have risen from 15% to 20%, and we need to investigate that. I'm happy at the Ministry of Health we have a NASMEC committee in charge of PET, or hypertensive disorders. They'll be able to investigate that. New risks such as anesthetic complications. For very long, we had neglected this area, and now it's coming up. And DG, I want to promise that we are going to address this. This is within our means to address. Anesthesia, the medicines that we give, are a challenge to our mothers at some points. Next. So when we did a deep dive, and this will be found in your report, those who want to understand the detail, because obstetric hemorrhage also is broken down. Bleeding can be before childbirth, can be after childbirth, and PPH is the one after childbirth, is the most common one at 80%. The one at 20% is before childbirth. So PPH contributes 80%. We have the drugs, and we want to make our messaging very clear that we now have the drugs in our health facilities. We have newer commodities that are very effective, including heat-stable carbetocin that we've received with the support of our partners. The highest reduction in PPH was due to uterine atony. Because of the new commodities, we've been able to reduce PPH, and we continue to reduce that. Increase in PPH after C-sections is an area of concern that we shall address. Next. I wanted to mention that under PPH, we still have cultural practices. Cultural practices where we have members of our community taking drugs that are uterotonic. Uterotonic means they cause the uterus contract. When you contract the uterus, and this is for our Royal Highness, especially, I don't know what is in Imumbwa, but there are other uterotonics that mothers take. By the time they come to the hospitals, the uterus has ruptured. Because if you take some of these local medications without the opening of the uterus being open or adequately open, then it will appear like a blockage, and the uterus will continue to contract, and that can cause the uterus rupture. When the uterus ruptures, the chances of survival are reducing. You can lose life in the next 2 hours because the bleeding is really massive. So this is what we are describing. Next. This will be in the report. I don't want to take you through the detailed, but this is granulating per region and where we have issues. Please, if you're in red, kindly address that. But importantly, we notice a reduction in avoidable factors contributed by delay number 3. We still have challenges in delay number 1. We need to do a lot. Delay number 1 is happening at the community. My husband is not around, I'm not going to the hospital, I need transport. I need first go through my Senga to give me permission. I cannot go, I have delivered all my babies through Mama Tendo. So all these delays at community, by the time everything has gone wrong, the health system doesn't do much. We notice an improvement in delay number 2. The roads are getting better. We still have problems of floods and water bodies. But the Ministry of Health has procured 300 ambulances and distributed them, including on water bodies, and we appreciate government for that. So we are also working so hard to reduce the delay at facility level by making sure everything is available. So everything about the delays is critical, especially delay number 1. Next. Key recommendations. I think I'm coming towards the end. Service delivery. We think and we recommend to implement and monitor regional health center for functionalization. A health center for, which is soon transitioning to a community hospital, is our lowest level where we have a theater or a doctor at that point. In the structure for community hospitals, they will have 5 doctors, and I hope we shall have the funding to make sure that we have 5 doctors at Health Center 4s. We want 24/7 attendance to emergencies. The mothers who die are not by accident. They all present as emergencies. You need the highly specialized people, the doctors at health center force. Most of them are in the villages. And we need to have that. That is directly within our means. Health workforce, we are happy, Madam, Your Royal Highness, our employer, the Health Service Commission chairperson is here with us, Dr. Henry Mwebesa, and we need to have more midwives so that we have better access at lower level health facilities. Of course, this goes with funding, and our partners, we are happy if you can support us in this. Commodities, we have been stable despite the financial disruptions, but because of the increasing numbers, 2 million deliveries a year is not a small number. We're always in need of more supplies, in need of more commodities. We have newer commodities that are being studied and are going to be piloted in Uganda, like Celox PPH, for preventing bleeding amongst, I think there is a stall out there. You should be able to see a stall of Celox PPH. And one of the new commodities that stops hemostatic device that stops bleeding from uterine atony immediately, including tears. Information systems, we are very intentional in using data for evidence-based decision-making. As you have seen, we are so detailed, we know almost what is happening at village level. And through the community health extension workers, we've developed an electronic community health information system that now picks information from the village level about health. Leadership and governance, this is the driving wheel for all this, and accountability. I can assure you, the Minister of Health, and we shall have the statement from the Minister, is more than ready to drive Uganda's agenda to make sure that women are not dying and babies are not dying and surviving. Next. I want to thank you all for listening and for this opportunity to share with you the State of the Nation address. Thank you very much.
Safe motherhood is far more than an item of just the Ministry of Health's checklist. We had a long report, we know they've done a lot, but it really concerns all of us. It's an economic, social, and political imperative that touches every sector in Uganda. When a mother thrives, her family is stable, and the community flourishes. So safe motherhood is an engine of human capital development, which is the key driver of national economic growth. Therefore, it should be a concern to all of us. And safe motherhood is indeed a multisectoral imperative. Achieving safe motherhood requires contributions from every sector of government and society, as well as the private sector. A few examples for those of you who are already here today. For those from the education sector, safe motherhood begins by keeping the girl child in school, empowering her with knowledge and choices before she becomes a mother later on in life. We already heard from the Ministry of Health the much higher risks of maternal mortality for teenage mothers. But a World Bank study from 2011 also showed us the economic benefits of keeping girls in school and avoiding teenage pregnancies. It shows us that 1 extra year of primary school education boosts girls' future wages by 10 to 20%. And 1 extra year of secondary school adds another 15 to 25%. So education significantly boosts women's future income and thereby strengthens the entire economy. For those from the Ministry of Roads and Works and Transport, safe motherhood also depends on well-maintained roads that allows an ambulance or other transport means to reach a remote village, or as we have heard, a remote part of Kampala, in time for an emergency and transit back to a health center facility. And for the Ministry of Finance, safe motherhood is to be considered a critical investment. Every shilling spent on quality maternal and newborn care yields a return in productivity and social stability. So collaboration across ministries is essential because the survival of mothers is closely linked to the success of multiple sectors. When ministries work together, their combined efforts are far more impactful in improving maternal health outcomes. But we should also involve the private sector. The private sector should invest in digital health and local supply chain innovations. areas that offer a clear return on investments while also supporting ethical service delivery for pregnant mothers. Distinguished guests, Denmark and Uganda share a belief in human dignity, equality, and sustainable growth. Within Denmark's bilateral partnerships here in Uganda, gender equality and protection of marginalized groups and youth are cross-cutting objectives. Maternal health is recognized not only as a health issue, but as a fundamental right, empowerment, and equity issue. A prime example of this commitment is Denmark's support for the Strengthening Adolescent and Youth Empowerment and Rights Program, or as we call it, the SAY program. This program is a collaboration between UNFPA, Mary Stopes International, Care International, Naguri Teenage Center, and the Ministries of Health and Education. It empowers young people, both girls and boys, with sexual and reproductive health and rights, life skills, and community voice. And earlier this year, I had the privilege of meeting some of the young people we supported in West Nile and who are engaged with the SAY program. One, and I must say very young, mother in West Nile told me the story of how, after her unwanted and very early pregnancy, with the program, she was supported to access the desired family planning services, to return to her studies, and she's now working towards completion of her Senior 4 exam. To me, that shows us that even if you do become a mother at a time in your life that you don't want to, and when you are still a child, with the right support, you can be given the opportunity to continue your education and become a productive member of your community. Another peer educator, or as we call them, our male role models, so our role model boys, was telling us how he and his peer role model boys now lead community dialogues on safe motherhood, dispelling myth and promoting antenatal protection. The importance of involving boys and young men in advocating for safe motherhood and the rights of girls cannot be underestimated. These stories from my trip to West Nile are not about abstract policies. They are about real lives, real futures, and real hope for Uganda. And they remind us that safe motherhood begins long before a pregnancy. By empowering young men and women, we are shaping informed choices, healthier pregnancies, and stronger communities. The stories also remind us that accountability begins early. Our investments in maternal health, youth programs, and community accountability are not separate silos. They are integrated strands in Denmark's partnership with Uganda. And for Denmark too, accountability means ensuring that every single shilling that we spend here is used transparently and reaches the mothers and the young people it was intended for. And let's not forget those at the front line. The midwives, the nurses, and the community health workers who embody the multisectoral collaboration every single day in their work, who bridge the gap between the policy, the financing, and the mother in the delivery room. They deserve our accountability, they deserve our investments, and they deserve our respect. Ladies and gentlemen, as we've heard, to reduce maternal mortality in this increasingly unpredictable and challenged financial environment also demands us to be bold and creative with our financing, moving beyond traditional aid models. This means, among other things, embracing local innovation. Look at the digital health solutions, the apps, and the local supply chain innovations that we know have been developed right here in Uganda. These are low-cost, high-impact digital solutions, and they're often the smartest investment when you have a tight financial landscape. Doing the leapfrogging, getting away with more expensive models, using technology to get to a point where we can use our financing smarter is not just the smart thing to do, it is also very necessary in the current environment. And Denmark supports the development of these vital digital tools, demonstrated through initiatives which empower midwives and save lives and money. Distinguished guests, as I conclude, the most profound collaboration is not only between ministries or between ministries and development partners. It is between a health system and the community to which the family, the mothers belong. It demands accountability across all levels of leadership, from the parliament where policies and budgets are shaped, to ministries where priorities are set, to cultural and religious leaders who guide social and cultural norms, to development partners like ourselves who must be transparent and efficient in our support, and finally to the families and communities themselves. This is the true meaning of multi-sectoral collaboration and mutual accountability. Every sector, every leader, every partner, every household sharing the responsibility for one mother's survival. So let's leave this conference determined, collectively, not to let strengthening multi-sectoral collaboration and mutual accountability remain a tagline. Let it become a lived practice, investing wisely, demanding accountability fearlessly, and working tirelessly across all sectors and communities. May the moment of giving birth be marked by safety, dignity, and joy as a true celebration of human potential. I thank you and encourage us to Tukolora Wamo. Thank you.
On behalf of civil society in the room, can you wave? Here we mean even implementing partners, not activists only and advocates. Thank you so much for coming. And as you can see, we make over 50% to 60% of the participants here. And we are here to affirm that this theme actually addresses our mandates. Because we are the ones that strengthen our sectoral approach, engagement, but also mutual accountability. We are called the Reproductive, Maternal, Newborn, Adolescent Health, plus Nutrition and Healthy Aging Platform. This platform is a global financing facility or World Bank mechanism that is charged to track implementation and the monitoring of the sharpened plan for RAMCA. That means that when we talk about mutual accountabilities embedded into the platform, we are a member of over 180 organizations. Those are registered, but those who are working on RAMCA are more than that. So Safe Motherhood is under that platform. We are here to affirm that the results that were shared in the reports and the presentations this morning are very true, but we are very grateful that we are all working together to see the progress that we've seen. The drop in maternal child health, but as our commissioner affirmed, newborn we are doing badly, but also teenage pregnancy is really dwindling. For over 10 years we are stagnant. And we are here to combine our hands, to put our heads together through this mass-sectoral approach to ensure that we address it. To give a snapshot, with the support of WHO and Ministry of Health itself, through the UCREP World Bank project, they supported us to conduct a social accountability exercise, which has just ended. And most of the findings affirm the gaps that have been highlighted, especially in service delivery. And I'm very grateful to our moderator in the morning, who is a champion and advocate for midwives. It was confirmed that we have almost, I can't say nothing, but in some hospitals like Mukono General Hospital, we found one midwife assisted by interns serving 200 mothers per day. And Mukono is just here. What about other hospitals that are out of town, and even in terms of monitoring, the supervision is very minimal. So we are here to advocate. As we sit in this conference, can we find strategies? Can we work together as partners, find resources? The Service Commission, and we are very, very happy that the chair is our own, the former Director General Health Services, who understands these problems. We are looking to you. When we're discussing and engaging, because we are trying to find a real gap with a commissioner, midwifery, according to the statistics, the new structure, service structure, and the old one, we need around 10,000 midwives to be able to address the gap. So we need to work together. The gap is real and the challenges are real. If we can be able to address that, then we'll be able to move on. The other challenge we found out was Whereas our commissioner affirmed that we have medicines and supplies for maternal and child health, we realized that the stocks are doing very well in joint medical stores and also the health facilities, but the last mile delivery, when it gets to the communities, we still have a gap. Most of these were funded by partners, and you know what has happened to our landscape. So we need to work on the distribution and redistribution so that the last mile deliveries are happening. But we are assured by Ministry of Health that that is being done. When it gets to innovative financing or domestic resource mobilization, we've been doing this for over years, and we are glad that there's a shift. In the new budget, we got 4.4 trillion on the healthy sector, but that's healthy sector. But also we are very happy that we have what we call Vote 116 that goes to reproductive health commodities and services. We are advocating for more, but there are other ways. And in this meeting or in this conference, we are calling upon you. We've advocated that we get what we call sin taxes. When you drink beer, eat sweets or anything sweet, you're taxed. And that money right now is sitting in URA. So how can we get that money since they're affecting our health? And part of it is even reproductive health. How can that money come back? So that they address the damage that they are causing, including our newborn. You know what happens. I'm not a medical doctor, but I'm a public health. The medical doctor can explain what happens with smoking and alcohol to mothers who are expecting. We are also here to talk about when it gets to governance. We realized or found out that there are a bit of functional structures in terms of the healthy, the DHTs and the HUMICs. Those are the government structures. The healthy facility, the functionality, and the integration is still lacking. Now to our commissioner, Dr. Kabanda, our champion for community systems. We appreciate where we went, and we have already queues working alongside VHTs. The integration is happening, and mothers are being followed and free referral. But we have now only 36. You're yet to confirm whether you've added more. But we have over 156, if not 60-something districts. How fast can we move to make sure that the referral system that has been affected by the cuts is addressed? Because we know that this cutting affected around 4 areas. One was community engagement and outreaches. It affected the redistribution. Now, if we don't get a strategy of addressing those gaps, we are going to get challenges. We applaud again the government of Uganda for coming up with other strategies. One of them is the integration agenda, where now we've addressed the silos, and we are looking forward for that strategy, but also developing the sustainability roadmap that is also being worked on. However, if we are to address some of these challenges, we need to get the systems work together. The integration speaking to sustainability, the community healthy systems working for extension workers, but very, very important, we cannot stand here and we don't call for ensuring that we have a national health insurance. Because if we have a national health insurance, the integration system is working, a very clear roadmap. And then we have our queues or community health extension workers. The investment that we have will be able to be efficient. Once again, we commit that we are going to be with you throughout this conference to come up with strategies. And not until we reduce teenage pregnancies and we don't see any mother dying and the newborn challenges are addressed, we will not rest. We are foot soldiers and we are advocates who continue to serve with you. Thank you so much.
The Chief Guest, Her Royal Highness, the Queen of Uganda, Nabagereka Sylvia Nagenda. Ladies and gentlemen, allow me to stand on the protocol that has already been recognized. And good afternoon. My name is Susan Kanyemibwa. I'm the Bank Secretary, Bank of Uganda. I bring you warm greetings from the Governor, Dr. Michael Atingego, who, due to other pressing central banking commitments, is unable to join you today. However, he sends his best wishes for a fruitful and inspiring conference, and I'm very honored to deliver his remarks on his behalf. It is a profound privilege to be part of this gathering, one that speaks to the very heart of our nation's future, the health, dignity, and well-being of Uganda's mothers and children. The theme of this year's conference, Strengthening Multi-Sectoral Collaboration and Mutual Accountability for Safe Motherhood, reminds us that safe motherhood is not just a health issue, it is a human development issue. It affects our economy, productivity, and intergenerational well-being of our people. Allow me to commend the Ministry of Health and all the partners for bringing together such a diverse group of health professionals, educators, policymakers, civil society, and development partners, each playing a vital role in safeguarding life and nurturing hope. For decades, Uganda, like many other developing countries, has benefited immensely from donor support in sectors such as health, education, and governance. These contributions have saved lives, built systems, and strengthened our national capacities. However, the global financing landscape is changing. Donor priorities are evolving, and external support is becoming less predictable. This moment calls for a bold transition from dependence to self-reliance, anchored in sustainable domestic financing that reflects our national values and priorities. Domestic financing is not simply about finding new sources of money. It is about taking ownership of our development agenda. It is about ensuring that essential services like maternal and child health care continue uninterrupted, even when donor flows are fluctuating. This points to the heart of sustainable development, which is put in simple terms as development that meets the needs of the present without compromising the ability of future generations to meet their own needs. Now, at Bank of Uganda, we recognize that sustainable development thrives on strong, stable, and inclusive financial system. As the nation's financial steward, we play a key leadership role in fostering economic stability, prudent resource management, and sustainable health financing. By ensuring financial stability, price stability, promoting financial discipline, and strengthening the financial sector, Bank of Uganda helps create an environment where government and partners can plan, invest, and deliver essential health services with confidence. At the bank, we also nurture an environment where financial inclusion is deepened, ensuring that women, especially in rural communities, can access and control financial resources to support their families and livelihood. This is how financial leadership and economic stewardship directly contributes to advancing safe motherhood and maternal health outcomes across the country. Now, back home at the central bank, beyond our core mandate of ensuring price stability and a sound financial system, which I'm proud to say that we have done very well, Bank of Uganda believes that economic progress and human being can go hand in hand. Through the bank's corporate social responsibility initiative, I also stand here on my own behalf as the head of the Corporate Social Responsibility Initiative at the Central Bank. And our theme for the Corporate Social Responsibility is maternal and child health care for a healthy society. And I think it resonates very well with the theme of today. Bank of Uganda has so far invested in healthcare infrastructure development and donated medical equipment in 13 health centers across the country. And we are still going strong. These 13 health centers include Wizwera Health Center 4 in Mbarara District, Ayivuni Health Center 3 in Arua District, Nakaloke Health Center 3 in Mbale, Omel Health Center 2 in Gulu, which has since transformed into and upgraded to a Health Center 3, Budondo Health Center 4 in Jinja District, Chanamkaka Health Center in Masaka District, Rutete Health Center 3 in Fort Potro District, which has now been upgraded to Health Center 4, Hamurwa Health Center 4 in Rubanda District, Rubaya Health Center 4 in Kabale District, Roburunga Health Center 3 in Mitoma District, Magoro Health Center 3 in Katakwi District, Chigorobia Health Center 4 in Hoima District, and more recently, Ayago Health Center 3 in Lira City. At this juncture, allow me to introduce a colleague that I work with, Sarah Mwaka. She's a lawyer in the central bank. However, she's the one in charge of the projects, so she will move around, and she has worked very closely with the Ministry of Health at the expense of being called a doctor. The bank has also been in funding other several projects in support of maternal and child health care. We've supported organizations like Rotary, clubs, and other organizations that have projects that resonate with our theme. These interventions reflect our belief at the bank that investing in the health of mothers and children is an investment in Uganda's human capital, and therefore, Uganda's future. To sustain the gains, but before I get to the gains, in addition to the health centers that we have supported, and we are still supporting, this financial year, the Bank of Uganda is taking up yet again other 3 health centers, and with the support and recommendation of Ministry of Health, we are taking up a health center in Kasese District. We are also going to support a health center in Kitgum, and we are also going to support a health center in Moroto District. We are trying to traverse the entire country and see where we can help. And not only do we do construction of maternity health wards, but we also support in procurement of equipment. And this equipment is not determined by us, the central bank. It is determined by the districts and the health center. So they give us a list of the needs that they require, and then we approach the medical stores and we procure that equipment. So to sustain the gains in maternal and child health, we must all be committed to strengthening domestic revenue mobilization through, for example, fair and efficient tax systems, prioritizing health in our national budgets with clear allocation to maternal and child health, leveraging digital financial services to improve access and reduce transaction costs, engaging the private sector as an equal partner in financing and delivering health services, promoting financial literacy, especially among women, to enhance economic empowerment and resilience. Ladies and gentlemen, sustainable domestic financing is not a distant dream. It is a national necessity. It is the foundation upon which we can build Uganda, where every mother survives childbirth and every child can thrive. As our neighbor, President Paul Kagame of Rwanda once noted, and I want to quote, he said, "We must mobilize more domestic resources to finance our development. This is the only way to ensure ownership and sustainability and accountability," I quote. On behalf of Bank of Uganda, I reaffirm our commitment collaborating with government, the private sector, and development partners to make safe motherhood not just a goal, but a guarantee. Together, let us build a Uganda where strong health systems, inclusive finance, and shared responsibility pave the way for healthier families and a more prosperous nation. I thank you very much for listening to me, and may God bless you all.
Don't get tired of clapping. Please clap for her. Our next speaker will be the chair of the development partners.
Thank you very much, Dr. Olaro. Good afternoon. Our chief guest, Her Royal Highness Nabagereka Sylvia Naginda, Queen of the Buganda Kingdom. Mr. Kenneth Akiri, Under-Secretary of the Ministry of Health. Honorable members of Parliament here present. Her Excellency Ambassador Sine Winding Albjerg, Ambassador of Denmark to Uganda. Mr. Philip Smith, Development Director, FCDO, British High Commission. Director General of the Ministry of Health, Dr. Charles Olaro. Chair of the Health Service Commission, Dr. Henry Mubesa. Madame Susan Wasigali, Bank Secretary, Bank of Uganda. Esteemed health professionals and development partners, representatives of all government departments, agencies, and ministries, dedicated cultural leaders and religious leaders, ladies and gentlemen, all protocols observed. It is an honor to join you this afternoon on behalf of the Health Development Partners Group and the United Nations Population Fund. Allow me to warmly congratulate the Ministry of Health, the National Safe Motherhood Committee, and all collaborating partners for bringing us together for this 5th Safe Motherhood Conference under the powerful theme, Strengthening Multi-Sectoral Collaboration and Mutual Accountability for Safe Motherhood. Uganda has made significant progress in improving maternal and newborn health, and I think we've heard a very comprehensive report from Dr. Mugahi. The maternal mortality ratio has declined from 336 deaths per 100,000 live births in 2016 to 189 per 100,000 live births in 2022, a 42% reduction, saving thousands of women and girls who might otherwise have died giving life. More women, now 74%, are delivering with the assistance of a skilled birth attendant. Life-saving systems such as maternal and perinatal death surveillance and response, IMONC optimization, and midwifery-led models of care are transforming how Uganda prevents and responds to maternal deaths. We commend the Ministry of Health for institutionalizing MPDSR in over 95% of districts and extending its accountability model to include teenage pregnancy surveillance, ensuring that local leaders, schools, and communities act on evidence to prevent avoidable deaths and early pregnancies. These achievements are a result of a strong partnership and collaboration between government, development partners, civil society, and communities, anchored in the RMNCH Sharpened Plan 3, the Adolescent Health Costed Implementation Plan, and the Family Planning Costed Implementation Plan 2. Your Royal Highness, distinguished guests, despite this progress, we are reminded that safe motherhood is still not a reality for all. Teenage pregnancy continues to be one of Uganda's biggest public health and development challenges. For more than a decade, the rate of teenage pregnancy has remained stubbornly high at 25%. Compounding this issue, both last year's and this year's maternal and perinatal death surveillance and response reports reveal that 1 in 10 institutional maternal deaths recorded were in the age group of 19 years and under. This represents not only an unfinished agenda, but also a development deficit, because every early pregnancy is a lost opportunity for education, health, and empowerment, and the country's overall development. Uganda's persistently high teenage pregnancy rates poses a significant threat to newborn survival. Pregnant adolescents are not only at increased risk of maternal complications and death, but their newborns face elevated risk of prematurity, low birth weight, and neonatal mortality, contributing to the country's newborn mortality rate of 22 per 1,000 live births. Addressing teenage pregnancy, therefore, is not merely a reproductive health priority, it is a strategic lever for improving newborn outcomes and accelerating Uganda's progress towards the Sustainable Development Goals. We cannot achieve safe motherhood without keeping girls in school, providing sexuality education, and ensuring that adolescents and youth have access to accurate information, contraceptives, and HIV prevention services that meets their unique needs. The modern contraceptive prevalence rate has risen to 33% among all women, yet the unmet need for family planning remains high at 20%, especially among adolescents. Every additional point gained in contraceptive use prevents thousands of unintended pregnancies and maternal deaths, like Dr. Mugahi also highlighted earlier. At the same time, HIV prevention must remain central to our efforts. Uganda has achieved remarkable progress in reducing mother-to-child transmission from 18% a decade ago to below 7%, but adolescent girls and young women still account for the majority of new infections. A truly safe motherhood agenda must therefore integrate sexual and reproductive health and rights, HIV prevention, and gender equality as one. Your Royal Highness, distinguished guests, the Health Development Partners fully support the government's leadership and efforts to transition from fragmented plans to joint and pooled impact, to translate national strategies into measurable and equitable results. Through frameworks such as the Health Sector Development Plan, the Ministry of Health Strategic Plan, and the RMNCH Sharpened Plan 3, we are aligning our support for integration, efficiency, and sustainability. We are investing in digital innovations, community health systems, and midwifery leadership, the backbone of respectful, quality maternity care. We also commend the growing role of the private sector, from pharmacies and faith-based facilities to innovators and insurers, in complementing public systems, expanding access, and strengthening Uganda's health financing landscape. These collective efforts underscore the significant return on investment in maternal health, where $1 invested returns up to $11.9 in economic gains. As health development partners, we stand ready to accompany and support the Ministry of Health and all stakeholders in advancing a mutual accountability compact, one that measures not only resources spent, but lives saved, systems strengthened, and inequalities reduced under the one plan, one budget principle. This compact requires a multi-sectoral approach and interministerial coordination that includes mutual accountability towards the Office of the Prime Minister, the Ministry of Finance, Ministry of Education, local government, public service, Ministry of Gender, among others. Let us continue to be guided and informed through evidence-based approaches in designing high-impact interventions, including use of evidence from MPDSR, teenage pregnancy scorecards, and family planning dashboards to drive the needed collective action. Let us hold ourselves, government, partners, civil society, private sector, and communities mutually accountable for ensuring that no woman dies while giving life and no girl becomes a mother prematurely. As I conclude, now more than ever, with one death far too many, the insufficient progress made in saving mothers' lives and preventing unnecessary deaths should serve as a clarion call for urgent collective action by all of us. To the midwives, nurses, doctors, teachers, and community health workers represented here, you are the heartbeat of safe motherhood and our indispensable first line of defense in reducing maternal morbidity and mortality. To our political and cultural leaders, your continued leadership and voice are vital in turning evidence into action and leading to positive behavioral change. To the private sector and civil society, your innovations, investments, and reach are helping extend services up to the last mile. To our communities and parents, thank you for nurturing the change we all wish to see. You are not alone. And of course, to our development partners, a big thank you for the sustained support and commitment despite all the challenges. On behalf of all health development partners, I reaffirm our shared commitment to stronger systems, sustained financing, empowered communities, and the realization of every woman and girl's right to health, safety, and dignity. Thank you.
Thank you, Daniel. Without wasting time, I will invite the WHO representative, Kira Koch, who represented the World Health Organization representative, to make her speech.
Good afternoon. Good afternoon. That sounds better. Your Royal Highness, the Queen of Buganda Kingdom, the Undersecretary of the Ministry of Health, Your Excellency, the Ambassador of Denmark to Uganda, the Director Development, British High Commission, the Bank Secretary, Bank of Uganda, the Director, the Chairperson and Vice Deputy Chairperson of the Health Service Commission, the Director General of Health Services, representatives from government ministries, departments, agencies, health development and implementing partners, district leaders, health implementers, civil society and private sector representatives, health professionals. Ladies and gentlemen, good afternoon. First of all, let me send warm greetings from Dr. Kasonde Mwinger, the WHO representative to Uganda, who is unable to attend today, and I will be delivering her remarks. It is really an honor and a privilege for me. It is my first National Safe Motherhood Conference, and I'm looking forward to many more of these conferences. And to join you today here at the 5th National Motherhood Conference, it is really a vital platform for all of us to be united. Policymakers, practitioners, academics, communities, around a shared vision that no woman should die while giving life and no newborn should succumb to preventable causes. Uganda's impressive reduction in maternal mortality from 336 per 100,000 live births in 2016 to 189 per 1,000 in 2022 is a powerful testament to what is possible when leadership, partnership, and evidence-based actions are coming together. This progress contributed significantly as well to the 10% global improvement in maternal mortality during the same period, from 220 to 197 per 1,000 live births. On behalf of the World Health Organization, I would really like to congratulate the government of Uganda, the Ministry of Health, and all national and international partners whose unwavering commitment has made this achievement possible. Yet, even as we celebrate, we must remember every maternal or newborn death is a preventable strategy. a preventable strategy. Sustaining the momentum requires not only the health system to come together, but a multi-sectoral collaboration. Safe motherhood is not the responsibility of the health sector alone. It is shaped by education, by nutrition, by gender equality, by transport, by financing, and community engagement. Each sector holds a piece of the solution, and our collective accountability will determine the future of maternal and newborn survival in Uganda. And this is precisely the reason why this year's theme, strengthening multi-sectoral collaboration and mutual accountability for safe motherhood, is so timely and profound. To truly advance safe motherhood, we must move beyond silos, and build systems of shared responsibility guided by data, equity, and most importantly, the voices of the women themselves. Mutual accountability means aligning our efforts around a common results framework, ensuring that commitments translate into measurable impact and that every mother, regardless of their location, can access quality, respectful, and life-saving care. WHO continues to emphasize that safe motherhood requires both a whole-of-government and a whole-of-society approach. And in order to support this, WHO has provided several guiding frameworks, including the Health in All Policies, integrating health across all areas of policy making, the Afro multi-sectoral strategy for health and well-being, urging government to mainstream health impact assessment and build accountability strengthening, and certainly the Every Woman, Every Child strategy, promoting inclusive, country-led platforms that align financing, technical support, and accountability. But how do we translate these strategies into measurable outcomes? And let me just highlight one concrete example. Over the past 5 years, WHO has been working hand in hand with the Ministry of Health and Quaker to implement a health system strengthening project in the Busoga region. This initiative focused on improving referral systems, upgrading 28 health facilities, providing equipment, building health workforce capacities, and strengthening district leadership and governance. While detailed results can be heard later during the session, and obviously I'm encouraging all to attend, allow me just to highlight 3 key achievements in the spirit of multi-sectoral collaboration. 1, health and education sector partnered hand in hand in order to improve access to sexual and reproductive health information in schools, helping prevent teenage pregnancies and reduce school dropout. 2, in collaboration with the water and environmental sector, water supply system and health facilities were enhanced, boosting infection prevention and control and overall quality of care. And lastly, working with local government, we strengthened health governance and data management, promoting local ownership and integration into routine health systems operation. This project has really shown the transformative impact of district-level leadership and cross-sectoral partnership in improving reproductive, maternal, child, and adolescent health outcomes. Ladies and gentlemen, esteemed delegates, WHO remains a steadfast partner to the government of Uganda and all stakeholders, providing technical assistance grounded in evidence and global best practices to advance our collective reproductive, maternal, child, and adolescent health agenda. Our collaboration will continue to focus on strengthening not only access, but also the quality of care through the WHO Quality of Care Framework, enhancing emergency obstetric and newborn care capacity, supporting national policies, data systems, and performance assessment, as we have heard earlier by Dr. Mugahi, including the maternal and perinatal death surveillance and response system. And lastly, promoting innovation and community-based solutions to ensure no mother or newborn is left behind. At global, regional, and national level, WHO will continue to advocate for investment in primary health care to achieve the novel goal of universal health coverage, the key foundation for sustainable motherhood. As we open this very important conference, I invite all of us to use this platform not only to reflect, but also to recommit to action, accountability, and collaboration. Let us ensure that our discussion translates into concrete, coordinated steps that bring Uganda closer to a future where safe motherhood is guaranteed for every woman, everywhere, every time. Distinguished delegates, Uganda's success story gives us hope, but standing and sustaining and accelerating progress required continued leadership, innovation, and solidarity. WHO remains committed to walking this journey with all of you because safe motherhood is not just a health goal, it is a human right, a moral duty, and a cornerstone for sustainable development. Thank you very much.
Let's appreciate WHO and the UN agencies. As all of you recall, I've not been attempting to summarize because all of them are summaries. So I want now to invite the Development Director from the British High Commission, Mr. Philip Smith, who will speak to us. He's welcome. Put your hands.
Thank you, DG. Your Royal Highness, Excellencies, Permanent and Secretary, Ministry of Health, senior officials from the Ministry of Health, let me, in the interest of time, stand on protocols already observed. Distinguished guests, good afternoon. Let me start, following Dr. Richard's very informative and enthusiastic presentation, let me begin, Permanent and Secretary, by commending your team at the Ministry of Health and health professionals across Uganda for your tireless efforts to save the lives of mothers and children every single day. Uganda's progress in reducing maternal mortality is a powerful testament to your dedication. The gains are even more remarkable when we consider the strides made in reducing HIV/AIDS-related deaths and expanding childhood immunization. Ladies and gentlemen, 2025 has been a turning point for global development. The development landscape has been shifting. External financing for health is declining, and the focus is rightly moving towards sustainable, locally led solutions. And I want to again applaud the government of Uganda for stepping up to fill the gaps left by reduced external financing. The recent increase in health sector budget allocations means that Uganda now dedicates a higher share of its national budget to health than most EAC member states, a clear signal of commitment to self-sustainability. Beyond resource mobilization, the government has championed service integration to improve efficiency and patient experience. The successful transition of HIV programs and the effective response to the Ebola outbreak earlier this year offer valuable models for broader health system improvements. Your Royal Highness, the UK is proud to be a long-standing partner in Uganda's health journey, but alongside other bilateral partners in health, our role is evolving. The UK government will continue to support global health platforms such as Gavi, the Global Fund, the World Bank, and the UN, and especially those that scale up life-saving technologies for mothers and newborns. However, with reductions in our global health budgets, we are recalibrating our approach. And for the UK, this means moving from being a donor to being an investor, from a focus on direct service delivery in health to health systems strengthening, from providing grants to providing technical assistance, and from large-scale international interventions to a focus on partnership and supporting locally led solutions. Let's be in no doubt we remain committed to Uganda's journey towards better health outcomes, and we are moving from funding our own parallel programs to forging partnerships that empower Ugandan institutions and Ugandan health professionals to lead the way. This year, we've been working to strengthen governments at district and health facility levels, improving technical and soft skills of health workers, including in obstetric care and family planning. And with UNFPA and the ministry, we are working to strengthen the private sector to increase access to reproductive health services. Looking ahead, we're modernizing the UK-Uganda health partnership. We want to promote deeper collaboration between Uganda and British institutions, including the UK's National Health Service, UK universities, and industry. We're very proud of these people-to-people connections in health. To date, these partnerships have delivered postgraduate medical training through the Tropical Health and Education Trust, a strong response to HIV/AIDS through decades of collaboration between the Medical Research Council, the London School of Hygiene and Tropical Medicine, UVRI here in Uganda, and Mildmay Hospital. We've improved cardiac diagnostics with the UK's Barts NHS Trust, working with the Ugandan Health Institute. And we supported kidney transplants conducted in Uganda through Manchester Royal Infirmary and Malago Hospital. And these initiatives, ladies and gentlemen, are a broad range of long-standing clinical exchanges with the National Health Service in the UK. These are investments in people, investments in knowledge, investments in innovation. They're not about aid. They're not about being a donor. They are about mutual growth, mutual and shared expertise, and a deep, long-standing partnership. They reflect our belief that linking Ugandan and UK innovation in health can deliver better health outcomes for the UK and for Uganda. Let me briefly reflect on today's agenda. The emphasis on integration, innovation, and community-led solutions is commendable. AI is changing our world and transforming healthcare globally, and the UK is keen to support Uganda's digital health revolution. The focus also on adolescent health and on teenage pregnancy is critical. Unintended pregnancies amongst adolescent girls threatens Uganda's progress in maternal health and its tenfold growth strategy writ large. And the UK is ready to partner in generating evidence of that to inform decision-making. Innovative financing, especially health insurance, as other speakers have highlighted, is essential to Uganda's health security. We welcome collaboration around the UK's experience of this and supporting Uganda to accelerate its domestic financing strategies. As the bank secretary has just mentioned, domestic revenue mobilization is a national necessity. Her words, not mine, and I'd agree. And this is about domestic revenue mobilization, but it's also about accelerating domestic financing strategies. So as we begin this conference, I encourage us all to reflect on how we can deepen collaboration, close persistent equity gaps, and ensure accountability for results that truly change lives. And as I conclude, let me say that the UK remains a long-standing friend of Uganda. We continue to deepen the partnership and the enduring people-to-people relationships between our countries, not least in the health sector. Safer motherhood is everyone's responsibility, and indeed, it is our shared opportunity. Thank you very much.
But I'm happy to be here to participate in this 5th Safe Motherhood Conference. And we all know that this conference always brings us together. I think this is the 5th, yes. We all meet here as stakeholders to discuss issues related to the safety and quality of our mothers and infants in this country. What is most exciting this year is the theme, strengthening multi-sectoral collaboration and mutual accountability. First, on multi-sectoral collaboration, because improving safe motherhood cannot be a role of Ministry of Health alone. It cannot be a role of government alone. All of us, like we are represented here, we are stakeholders in improving safe motherhood. Other ministries, development partners, even civil society, private sector, the community, we all play a role in this. But we are also excited about the issue of mutual accountability. As you are here, you ask yourself, what have I contributed to safe motherhood this year? I'm an IP, yes, but what have you done? We are Health Service Commission, yes. Have you recruited the midwives they want? You are a District Service Commission. Have you recruited the midwives they want without charging them? So those are issues that we also ask ourselves, mutual accountability. Guest of honor, Mugahi made a very, very good presentation where he highlighted all the achievements, the reduction in maternal mortality, the improved safe deliveries in hospitals, reduction in infant mortality, and all the figures he presented there. And I really not bore you going through them. I have a whole page here, but I will not go through them because you have them in your reports. But 2 things I want to request from that. 3. 1, Madam, there was the issue of teenage pregnancy. It came out strongly. And you have been doing a lot of work in that area. We request that you continue to attach special interest in that problem. But not only you, mobilize your other colleagues, the queens in the different regions. Let them also take special interest, and we address that problem. 24% of teenage pregnancy is really a big problem. The other day we were using excuses of COVID, that children were getting pregnant in COVID, but COVID ended. Why are they still getting pregnant? It's a problem we must address. 2, Charlotte, you are carrying a ruvengo, and that ruvengo is not small. The issue of bleeding, our mothers bleeding after delivery. We really thank you for coming in. Please join us, and we address that problem. You saw in the presentation, they said 44% of our mothers who die. It is the cause. 44% is not small, really. 44% is a big problem. So if we address that problem, then we would have cut off a lot of deaths to our mothers. So we request you, join us, work with us, and we address that problem. Even if it means mobilizing general, and say, General, I've been given assignment. You know what I mean. You know the general I mean. I've been given this Ruvengo. Can we carry it together? He can even mobilize for us blood from UPDF. He can come in different ways. But tell him it is a big problem. And since we are talking about sectoral collaboration, we are all working together to address this problem. Number 3. You know, in Uganda, we are very good at shouting horse for the wrong things. What we have not done, the borders, the potholes, but we do not shout horse on the good things that this country has done, the government has done, and we ourselves have done. Because all these good things that Mugahi presented here, they will end up here. You are preaching to the converted, everybody here knows them. But does the population outside there know the great work that has gone in to address this challenge? all these improvements. The deliveries in health center series, those health center series didn't sprout out like mushrooms. Somebody built them. The health center 4s, the cesarean sections at health center 4s, somebody did them. The sector did them, government did them. So we should also try to tell the world of the good things we do in this country, and so that everybody knows that there is good work going on somewhere. I come from the Health Service Commission, so I would want to conclude by talking about something to do with the health workforce. May I at this juncture request my colleagues from the Health Service Commission to stand up for recognition, the Deputy Chair and members, and may I also request our elder and the person who groomed us, Professor Pius Okong, to stand up for recognition, because we are following in his footsteps. Thank you very much. So I want to mention a few things to do with health workforce, especially in safe motherhood. When they were doing the tallying here, it came out clear that we need more midwives, we need doctors, we need health workers. That is very true. If we are going to improve safe motherhood, we need more midwives. So Health Service Commission, we need to recruit midwives. District Service Commission, we need to recruit midwives. We need to recruit doctors, and we need to recruit anesthetists. Because really for me, a health center 4, which is not doing operations, is not a health center 4. A health center 4 must do cesarean section, and therefore you must have a doctor there, and we have doctors. We have doctors there and do cesarean section on our mothers who have not been able to deliver normally. In fact, a health center 4 to me, we did it last year, you remember? We went in one district, we found a health center 4 with 2 doctors with receiving money, but they were not doing cesarean section. So we directed, the good thing we were with the PS. PS said, I've given you 2 months. If you do not start doing cesarean section, I'm going to cut your budget and take you back to a health center 3. Because a health center 4 not doing a cesarean section is a health center 3 to me. So let's actually analyze all those health center 4s who have doctors and anesthetists and are not doing cesarean section. And what is annoying, they get the same amount of money. Can you imagine a health center 4 like Wakiso doing about 120 mothers cesarean sections per month? Gets the same amount of money with a health center 4, which is doing 0 cesarean section. What is this? What leadership is this? There's no way you can, I get the same amount of money, I do 120 cesarean sections, you do 0 cesarean section, and you get the same amount of money? Surely. I think that's unacceptable. Because we have seen health center 4s in Tusi, Sembabule, Chana Mukaka, Kumi, doing very good number of cesarean sections. So you who are not doing cesarean sections, why are you getting that money? You 2 doctors there, what are you doing there? So DG, those are areas really we must address seriously. Then the next is adherence to schedules. We do duty rosters. If a mother has struggled and come all the way from down, including those in Kabale who come on, is it called Ngozi? And he reaches a health center and finds a staff not there, and yet the staff is on duty roster, showing that Mwebesa, I'm supposed to be on duty, and I'm not on duty, and they lose that mother. Why should we tolerate that kind of behavior? So we must also emphasize those areas that doctors, staff, nurses must adhere to their duty rosters. We have an electronic medical records. Now, if I go for supervision, and you DHOs who are here, I go to Chana Mukaka Health Center, for example, or even, let's say, Mpigi Health Center, and then find out, has Mwebesa been working this month? 22 days. Maybe did 20 days. You can excuse me for the 2 days. But we've been to places you find somebody has worked 9 days out of 22 days, 8 days out of 22 days, and we are supervisors. Surely that should not be accepted, because that's how we lose our mothers. Next, It's not a question that Mwebesa came, because we also know people come and clock in and then go to their clinics and come and clock out in the evening. We should go further to find out when Mwebesa came in October, what did he do? You are a doctor, how many scissors did you do? How many ward rounds did you do? How many investigations did you do? Is that too much to ask? No. Even with this increased salary, and you are begging people. The other day we advertised for 16 jobs for doctors. We got 1,400. So why are you begging a doctor who doesn't want to work? We have so many doctors on the street. We have so many midwives. So let's really take it very serious. I have one or two more comments. The issue of the community health workers. And I'm happy Kabanda is here. If we are going to improve services, we really need to start from the community level. And I'm happy about the program, about the community health extension workers. Those tools will help us to tell mothers, go for antenatal care, go for family planning. You have been pregnant, I've been monitoring you, go and deliver in a health facility. So I beg the Ministry of Health to expand that program, but also donors to support that program of making sure that every district has got CHOOS. This is a sensitive issue, but I have to talk about it. Because it was presented by the IGG, so I'm not creating it, that we know that sometimes at the district service commissions have been charging staff for appointments. Now you recruit this nurse and she pays you 80 million to get that job. What do you expect her to do once she comes in service? The first thing is to recover my 80 million, because I could have borrowed it, I could have sold something, my father's cows and the like. So this, now do you know what she will do? She will start charging our patients, our mothers. Now most of our mothers don't have that money. So you'll have a mother comes there, is not attended to because she can't afford to pay. And therefore, you have a mother rupture, you have a mother die in our facility. Actually, what they do, if you don't have the money, then they push you up. You go to the hospital, go to Emmanuel there in Kawempe, they push you out, further up. But by the time she reaches Kawempe, she's ruptured and she's dead. So government, we must find a way of solving this problem. Even if it means, I know the DG is about to chase me, let me stop there. But we need to address that problem, because now if I recover my 80 million, when I start the process of recovering my 80 million, by the time I recover it, I have already developed a culture of extortion. I will not stop at 80 million, then I will continue charging mothers. So let's really address that. Finally, Dr. Pius Okong, before he left, he had started a process of developing standing orders for health workers. We are finalizing those standing orders. And those standing orders will outline how doctors must behave. Because, we are using standing orders, the general standing orders for public servants. If I call a vet that my cow is sick and he doesn't come, the worst that will happen, my cow will die, and I will eat it. I will sell it at least, and we eat the money. Of course, I've lost my cow. But now, translate that to what? A mother. If the doctor doesn't come, a mother dies. So the rules governing a vet, the rules governing, let's say, an agriculture officer, cannot be the same as governing a doctor. So we are getting in place rules that health workers must comply to professional ethics. In the past, you would take, let's say, a year to discipline a health worker. The new guidelines, within 3 months, you'll have either been dismissed or you'll have changed your way of work. So, otherwise, I really want to thank the health workers for the great work that you do. I'm not sounding as if we don't do well, but I just wanted to caution our colleagues who do not adhere to the professional ethics. But otherwise, our health workers are doing very well, Otherwise, the health workers are doing a very good job. That's why you see those indicators have improved very well. That's why you see we are doing very well. And that's why you see even we managed to fight COVID, and we are one of the best in the world. Thank you very much for God and my country.